All right, we're all here. Let me take a quick roll call and get back on it, Trevor.
Here.
Thank you, Renee.
Hello, back here.
Thank you, Jesse.
I'm here.
Thank you, and Jason.
I'm here.
Thank you, everyone. All right, let's get started. Agenda item 10, discussion and consideration of compounding by pharmacy technicians outside of pharmacies. This next item for discussion was referred to the licensing committee from the enforcement and compounding committee. During this and other committee meetings, we have discussed the requirements for licensure for a pharmacy technician. By definition, pharmacy technicians work in a pharmacy under the direct supervision and control of a pharmacist. As the meeting materials highlight, USB Chapter 797 describes the minimum requirements that apply to all persons who prepare compounded sterile preparations and all places where sterile preparations are compounded. This includes pharmacists and pharmacy technicians compounding in places, including those areas outside of a pharmacy. As a quick note, Federal Law Section 503A of the Food, Drug, and Cosmetics Act makes clear that authority to compound a drug preparation is in part predicated on compliance with USB compounding chapters. For our discussion today, there are a number of policy questions intended to assist the committee in its assessment of this issue, which may be appropriate to address in the board sunset report. Unless members have any general comments, I will begin with the first question in the meeting materials. Should the board seek more explicit authority to inspect locations where pharmacy technicians are performing compounding activities outside of licensed pharmacies? I appreciate the note included in the meeting materials referencing Business and Professions Code Section 4008 that appears to already provide such authority, but perhaps we just need to provide educational awareness of the board's existing authority. I do think, though, there may be some improvements, some enforcement possibilities for pharmacy license by the board and the pharmacist. We can take quite a few actions. However, for non-licensed areas, I'm afraid there is limited actions that can be taken. So hoping to possibly bolster BPC 4008 in some ways to improve enforcement, at least add possible cease and desist or any increased fines or any ways. So with this question, starting with number one question to members, what are your thoughts? Agreement, disagreement?
I'll start off being
Go
one of
ahead,
the
Trevor.
public members. Yeah, being one of the public members and non-pharmacy members, I'm going to be listening a lot, but also want to just ask, just as kind of a clarifying question, what's the problem we're trying to solve here? What is the harm that's been done that is impelling us to move forward on this, and just so I can have greater clarification for how I'm thinking about
Thank
this.
you. Thank you, Trevor. Absolutely. Yeah. So I'll let Anne speak, as well as if any inspectors are present, please speak on this issue. But just the bigger picture has been, um, as what we usually look at is a compounding in a licensed pharmacy and technicians working in that environment under the direct supervision of pharmacists. However, there has been incidences of pharmacy technicians working in a non-licensed, such as IV hydration clinics or doctor's office, places that are not licensed by pharmacy and possibly not in clear regulation under Board of Pharmacy, but they're practicing compounding. And we have heard reports that their standards are significantly less than what we would expect for a pharmacy license by the board. So we're hoping to address in these areas where there's an opportunity for stronger oversight of the quality and standard for these facilities that are not licensed by the board, but the practice of pharmacy is somewhat practiced or dispensing is occurring of or manufacture or compounding has occurred in these places. Also unlicensed infusion centers or other areas. So that's kind of where we are. And I will, just so that I can add on, I will have Ann speak as well as there's any supervising inspectors or present. Cannot hear the room if anyone's trying to speak. Oh, and Christine is there raising her hand, so she's probably able to assist in this discussion. David, would you mind promoting Christina Costa to the panelists, please? And in the meantime, if you can have, and you can also speak on it as well. Christine, go ahead. You're promoted if you want to jump in.
Hello.
Hi.
So this issue becomes a patient safety issue because a technician, when working in a pharmacy, is under a pharmacist, and that pharmacist is responsible and directs all the practices that they can do, and then they are the final check of any work that a technician would do. When we see that technicians working outside of a pharmacy without direct supervision of a pharmacist, there is no oversight. The amount of education that a technician would have doesn't always lead them to doing things in compliance with even the minimum practice standards of USP. So we have investigated and received, I'll say many, complaints on technicians compounding and or practicing outside of a pharmacy where there has been harm or there's a high risk of harm. Does that help?
Thank you. Thank you, Dr. Acosta.
Yeah, so this is Anne. Sorry, sorry for the technology issues here. They're continuing. Just wanted to say, right, so USP is clear who needs to be complying with the standards, one of which is pharmacy technicians, right? And as Dr. Acosta indicated, we find that these individuals are compounding in less than standards that are, established in 797. So the question becomes, as our licensee, how can we more effectively regulate them to ensure consumer protection?
Absolutely. Thank you, Anne. Does that help, Trevor?
It does. I have one follow-up for both. So our focus is on regulating the pharmacy tech, because if by, and again, non-expertise view here, if compounding is happening at these locations, and they are not currently under the purview of the Board of Pharmacy, does that mean that the compounding they're doing is with drugs or whatever substances that don't fall under our jurisdiction? Like when I hear the IV thing, I think of like the hydration stations at Vegas after a hangover sort of deal. And so I'm just trying to clarify. I see our scope and responsibility as it relates to the pharmacy technician, but does the distinction of the type of substances these places that are doing these compounding, do they not fall under our jurisdiction? So that's just trying to what I'm getting my head around.
Great question. Christine, go ahead. Speak up.
So this is Anne.
So go ahead, Anne.
So I think it's important to recognize that our licensees may operate in a variety of different manners. What we find a bit of a dynamic is that sometimes pharmacy technicians are sought out to compound in some of these other areas. So that's, a part of the job, recruitment or whatever. That's a specific skill set that we're looking that the employer is looking for. What we find, however, is that unlike in pharmacies, there is no direct supervision and control over these individuals, and they're not, in fact, following many of the standards that are established in the USP. So, Trevor, I think kind of directly to your question, no, the board may not be the board does not have jurisdiction over the site per se, but it has jurisdiction over its individuals, right? We look at substantial relationship, we look at where people do it. And I don't know, a dumb example, but an example is behavior that occurs outside of a pharmacy is still jurisdictional for the board, right? A DUI, something like that. So same kind of concept, dopey example, so I apologize, but same kind of concept.
Thank you, Anne. Christine, feel free to add if you have any additional comment.
No, just adding to what Anne said is that we have the ability sometimes to enforce on a technician some things, but right now the way that we're struggling a little bit on my end as the inspectors is what we can stop a technician from doing when we know it is safe, or how we can go about doing that. If you look at how all of the pharmacy regs are looked at, it's the pharmacist who is accountable for the actions of the technician. It's not that I can go after, if there's a misfill in a pharmacy, I can't hold a technician accountable clearly for that. And it's the same basic process. If they are not, the technician is working outside of that environment where there is somebody to hold accountable that is overseeing them, the ability for us to ensure the safety of this practice by one of our licensees is very limited.
Yeah, and if I can just quickly add, right, we're talking in very general terms. We're providing very general kind of overview stuff, because any investigation that we do is going to be very fact specific. So I don't want people to take what we're saying here and say that it applies equally in all situations, because that's really not the case. We're talking in very general terms. And so just want to recognize that, some of what Christine and I are reflecting on might be different based on very, very fact specific, case specific conditions.
Thank you, Anne. Jesse, your hand is raised and you've been patiently waiting, so I'll go to you.
Hi, thank you. Sorry if it's loud in the background, by the way, but adding to that, just, coming from the NABP member forum back in November, I'm sure this kind of reiterates what Anne and Christine already said, but it sounds like a lot of these clinics, and like you mentioned, Trevor, the hydration clinic is a good example. They're kind of in a strange purview where they're a little unregulated in the sense that they don't really fall under a specific category, and there is compounding happening. I'm sure there's a lot of 797 standards that aren't being followed. Getting back to the original question, I guess I would hope that we can inspect some of the facilities, but then the next question becomes, how do we know if they're actually hiring a technician and have a technician compounding versus hiring a different type of clinician or person to actually perform those? And is that something that our board and our inspectors have the capacity to figure out when we're going into these sort of clinics?
Thanks for the comments, Jesse. Any other, Renee? Then I'll go to you, Christine. Renee?
Just going to address, no problem, sorry. Just going to address the question. We do know when they are licensed technicians. We do. Whenever we go in, we would figure out who is doing what their capacity is. And most of the time, they're very proud of being technicians. They'll be like, oh, I'm a pharmacy technician, or you'll check in at the front office, and they'll send us to their compounding expert, which is their technician, things like that. So it's usually quite easy for us to figure out that they're technicians.
Thank you.
Thank you,
Christine.
Hi, this is Renee. Yeah, I think in terms of this, for our first question that we're looking at, the authority to inspect locations where pharmacy technicians are performing compounding activities. So, I think we've had a lot of discussion on what pharmacy technicians are doing. So, I think the vast majority of pharmacy technicians are compounders, right? As described in USP 797. So they're very hands-on doing the work. And while they may, let's say if somebody has like impeccable aseptic technique and all of that, there's so much surrounding the environment of compounding, depending on what type of facility is there. And it's the location can really cause contamination. So, I mean, that was, one of many, many egregious things for NECC, right? They were next to a dump that was, blowing in air from, sucking in air from this dump. So, there's a lot going on that puts an injectable medication or fluid with a high probability of becoming contaminated. And then there's just the question of the environment. Is it being maintained with the right, there's just very specific types of cleaners, sporicidals that need to happen in order to maintain this environment, even for a really good compounding tech. And so that's the part that's very concerning, because that is where there will be harm. So I would definitely support trying to figure out how to have more authority. I mean, how to find them, like Jesse's point, how do you find it? Might be on a report, or it may be, somebody reports them, or it may be, a type of activity. But I think number 2 of when we get to there, I think that probably will help to address some of those points that, if people are not already following, that if they're not aware, some kind of educational material about that they are under those requirements if they're compounding.
Thank you, Renee. Okay, that's a good segue for us to move on to the question 2. Should the board develop educational materials to provide to other healthcare professional boards and associations, reminding such entities of the board's inspection authority? I firmly believe this is easy and appropriate. Also just suggest that similar to the board's current inspection brochure, that we develop something that inspectors could provide at the time of inspection to the facility that details the board's authority, purpose, etc. And so if members are agreeable on this one, we could definitely refer this to maybe Communication and Public Education Committee. Jesse, your hand is raised. Did you have something to add?
No, sorry, that was from the
Oh.
last one, but I do
Oh,
agree
okay.
that educational material should be distributed.
Okay, thank you, Renee. Mute.
Off of what I was mentioning before with number 1, I think the educational materials should be 2-part. One of them, I mean, yes, letting entities know that the board can inspect a location if there's, they think there's compounding there, just to evaluate it, but also what is required for compounding, like a reference to it, not the whole USP document, but in other words, they should be looking at these things, and they need to follow, because there's a lot there
Yeah,
that they
absolutely.
don't really quite realize, right?
I think what we are not, some folks may not realize is how high risk activity it is possibly, and how harmful it could be if it goes wrong. And I think that's where we would like to really highlight. Next question, so I just want to make sure, any other member comments? Okay, moving on to question 3. Generally, the board does not inspect facilities where compounding occurs outside of a board licensed facility unless requested by or referred to the board for such action by another entity. Do we believe this is appropriate, or should the board staff begin to perform some inspections of such facilities to learn more about the compounding practices broadly? I personally strongly believe it would be great to perform such inspections to gain a better understanding of compliance of board licensees with state and federal laws and compounding standards, but I am concerned the workload. So that is a little bit concerning because there are some statutorily mandated work that must be performed by our inspectors. However, I am deeply concerned of practices that are occurring out there at non-licensed facilities. So it's probably important for us to get started on starting some investigations and well, I can't call it investigation. I would say inspections at some facilities, especially ones that are maybe we're getting more complaints about. So members, your thoughts on this question? Trevor?
Yeah, I'm wondering if there is a way to explore expanding on this work in collaboration with our referring partners rather than statutory or big legal changes, because kind of the thing that's been going in my mind is like, okay, these pharmacy techs that are where I'm in the image. I'm just going to keep using the Vegas IV hydration clinic in my mind. This is kind of a side regulation of, okay, we know we can't do it, but this is kind of our in to kind of get a thumb in there, which I'm not belittling that. I'm just like seeing, like, that's how my mind is seeing it right now. And I'm wondering if, like, with the FDA, if the FDA, DEA has a particular concern about these hydration IV clinics, is there a way we as an entity can better engage with them to make the referral process easier? And would that be a more efficient, less cumbersome way for us to kind of have a foothold in this area to make sure that the compounding that's going on is appropriate and clear, and that farm techs are doing their job? So just kind of a stream of consciousness, but wanted to throw that out there.
Thank you, Trevor. Anne and Christine, did you have anything to say on that point that Trevor's bringing? I know you all have experiences, and I think the reason why we might be bringing this question up is possibly because there has been some struggles with working with these entities and them having two different standards of the Board of Pharmacy standards and other entity standards, and that we usually maintain higher standards.
So this is
So
Anne. Sorry,
go
if
ahead,
it's okay that I jump in. I think that and I certainly cannot speak for these other agencies, taking FDA out of the rest of the group. FDA has different kinds of resources, but
right.
for
Yeah.
a lot of the other agencies, they maybe don't have the expertise either on staff or that they contract with to really understand compounding practices, whereas we are very fortunate because we have licensed pharmacists that do all of this work for us and are very adept at doing that. So what we do find is others look to the board to provide guidance and assistance in some types of investigations and everything. And I think a lot of it is the nature of the highly qualified individuals that work for the board.
Thank you, Anne. Christine?
I just wanted to add that we do work with them. We have been on many joint inspections and investigations in clinics that are owned by providers or they're owned by an entity not regulated by the board. So we are again, like Anne said, we definitely provide any kind of guidance. I work with DFI all the time on their cases that come between this, but that doesn't necessarily leave us with the authority to do anything when we see a problem. And Sung, you are correct that our standard in a pharmacy is higher than in most of these locations. It's my experience that most of the other governing boards do not even require in statute or regulation the standards of USP. So they are tending to be less, even if somebody was going to regulate them.
I would just thank you, Christine, and just kind of, we don't we are, we have our swim lane that we're responsible for. All licensees, right, the authority to compound resides both in state and federal law. Federal law is pretty clear about what the conditions are for compounding, and it's not specific to just pharmacist, and USP standards, again, very clear about who it applies to. So I think that the standards are probably the same with the exception of potentially the board's regulations. But with respect to what federal law requires and those USP requirements and everything, it's pretty much standard across those that are authorized to compound under federal law.
But it's the enforcement. Okay, Jesse?
Yeah, kind of a follow-up to that. I know, I imagine things just work a little more slowly from when you get at the federal level of inspections. And so I'm wondering if there's some sort of collaboration we can do with the other California boards, like the medical board, physician assistant board, nursing board, so that there is an understanding, at least at the state level, of what the standard is. And if that's something that we can do like a collaborative effort on.
Thank you, Jesse. Any other comments from members? So, about answering this question, where are our members? Are we kind of looking for more into possibly inspecting or not really collaborating, trying to collaborate with other entities, which I think we've already tried, and not sure where we are really going with that. So, Trevor?
Yeah, I'll just say I have significant concern. I'm not necessarily opposed, but I have significant concerns. I mean, this to me looks to be a massive expansion of work for the body. In addition to, do we hold these non-licensed facilities to the same standards as licensed facilities, even though they have up to this point not been under any requirements? I think that is opening up a significant legal question that I think would be best solved at the statutory level. I think these are questions I think are more, or as far as question 3 about our ability to inspect facilities where compounding occurs outside of a board licensed facility, that's a question I think is more suitable towards the legislature answering that question rather than us as a body. I think that's a statutory, in my mind, much more statutory than us doing a rulemaking, say, okay, now we are going to go into the IV hydration clinic, and we've now decided that we can do that. So again, I'm not, if there is legislation that eventually is proposed, I'm not saying I'm necessarily opposed to it, but I think that's more where it lies rather than in a decision by us.
On that, Trevor, there is, my understanding is that there is a statutory authority already in our power in some ways under BPC 4008. However, have we proactively really utilized that authority is a different question. And I think that's why this question is being brought upon us, is to kind of further look at, should we try to make sure we need to maybe take a little bit more a stronger approach with the standards not coming along the way of where we have kept our standards. I'll let Corinne speak on that. Corinne, go ahead. Corinne
Yeah.
is our legal counsel. Go ahead, Corinne.
Can you hear me okay?
Yes.
Okay. Yeah, I just wanted to chime in on Member Chandler's question because, as President O pointed out, there is existing statutory authority in Business and Professions Code 4008, and specifically in Subdivision A, where it states that the board does have inspection authority to inspect during business hours, basically any place where drugs or devices are compounded, prepared, furnished, dispensed, or stored. So that was really the first question that was asked in this, series of policy questions was, even though we may have this existing statutory authority, is there, you know, some additional more explicit authority that the board might want to seek?
Okay, any Jason?
Thanks, Song. Thanks, Corinne. I think with that additional information, it's pretty illuminating, and I think that with a lot of these facilities compounding medications in an unsafe manner, I think that it would be in the interest of the board, in our role of maintaining the health and safety of the public, to at least proactively go out and investigate some of these facilities and let them know that the board has the ability, the capacity, and the legal right to do so. And I think it's good to put that information out there into the public that if you're going to be compounding these drugs or taking these actions, that you need to be compliant when you do so. So yes, to number 3, I would say yes.
Thank you. Thank you, Jason. Jesse?
Thank you. So I definitely think there needs to be more oversight. It's good to know that we can enter those facilities. I have similar concerns to Trevor, which is, you know, if we go into these facilities and say we don't have any licensees in these non-licensed facilities, but they're compounding or preparing medications in a way that doesn't meet the USP standards, what are the next steps that the board takes? Would it be the sort of thing that we refer to one of the federal agencies at that point? Yeah, I guess I need a better understanding of where our jurisdiction over these non-licensed facilities, when we don't have licensees, lies.
That's where I'm glad you're bringing that up, Jesse. Thank you. It sounds like from your question, you're seeing the point of this discussion today, which I'm very happy. That is the ultimate, I think, question of where we can go and what we need to do. So we'll further move along to question 4. Does the committee believe it is appropriate to allow for pharmacy technician to compound under the direct supervision and control of pharmacists when outside of a licensed pharmacy? I think that maybe one way of approaching this is that if you are doing this outside of a pharmacy, that you should have a technician and a pharmacist oversee, and I would be totally supportive of that effort. So wondering your thoughts on this, members. Jesse?
Hi, Sung. I absolutely agree with you. And from my understanding of the definition of a technician, they should not be compounding if there's not a pharmacist there anyway. So
nor outside of a pharmacy, yeah.
Or outside of a pharmacy, rather. And so that brings up another point too. It sounds like there may be technicians who are doing things that they may not legally be allowed to do. Whether or not they're aware of it is another thing, which is why I think the educational piece is so important. But that does kind of bring back a point from earlier, which is, should we as a board be looking into how to hold technician license accountable, specifically in situations like this, where they may be doing things under their license that they're not supposed to be doing. You know, when we have dispensing errors or what have you, it goes under the pharmacist's license. But if they're performing outside of their actual legal duties, then I guess the next question is, what are the steps that we take as a board?
And just to throw it out there, going there, it's a little controversial, but nothing stops them from using their technician license. It's the employment. So these folks could potentially just work without their license. And so that's the issue. It's a very complex issue that we're tackling today. Renee?
I understand, you know, your point about having, you know, I mean, initial concern is a licensed technician performing or compounding without pharmacist oversight. And then now you have a pharmacist with oversight over a compounder technician. But I, you know, I just, you know, like there's a huge array of types of compounding that this is so general, right? So are they doing the, like a bag here, a bag there for hangovers? Or are they making lots of bags to store on the shelf for a busy concert weekend? Like whatever their practices are, their environment, and all those things, like the risk just increases and increases, right? Just there's just a wide variety of what can be done. And so that would be my concern, is that it's not a licensed pharmacy. So at some point, if they're compounding and there's a pharmacist and a tech, can it not also be a licensed area? I mean, there's sterile compounding, you have your sterile compounding license for your room, every single clean room, right? In a facility, in a pharmacy. So, that just concerns me. I mean, I certainly understand the two, but together, but I still think that there's a lack of oversight, or like there's just no guarantee of the understanding of what's being performed and the risk. So
it.
yeah.
Okay, I see your perspective, Renee. Thank you. Certainly not a quick and easy discussion today on this topic. All right, any other thoughts before we move on to question 5, members? All right, next question. Should the board consider establishing a requirement for offices, clinics, etc., that are compounding but not currently licensed by the board to provide at least notification to the board that licenses are compounding, or someone is compounding at their location, or alternatively require board licensees to notify the board if they're compounding outside of a board licensed facility? Again, very complicated issue and very complicated question. I'm in support of minimum notification requirement established that if a board licensee is compounding outside of board licensed facility, they should at least notify the board of pharmacy. But I'm looking forward to hearing your thoughts, Jesse.
Hi, Sung. I think a notification has the potential to really overwhelm our board staff, because I imagine it's going to be hundreds of clinics that are probably performing this sort of thing. So I don't know if that's the most practical thing. I think it could overwhelm us. But if we are trying to go into facilities, we do kind of need some baseline to figure out where to start.
Thank you. All right. Any other, Renee? Oh, go ahead. Go
Yeah,
ahead.
I just was thinking, in looking at that, again, yes, that can completely overwhelm, our inspections. However, also could be a really important location. Somewhere down the line, I don't know, but establishing a requirement for offices, clinics, and this might sound creepy, but if you had, I don't know if they had a self-assessment that they do in their environment, maybe call it something else. But just for the compounding regulations, they complete something and have a like a attestation. I don't know, that might be a lot, but that might at least create some understanding of what's required if you're going to be in that spot, which also could make people not report, but I like to think people would report that they're working in a facility like that, especially if it was combined with the fact that inspectors can go to these locations.
Thank you, Renee. Trevor?
Yeah, Sung, I agree with you. I think if we're gonna basically kind of ease our way into this kind of realm, I think a really baseline would be having licensed pharmacy technicians alerting the board to when they're doing something outside of a pharmacy. And not that I think, I mean, I would love to hear from Anne about the concern Jesse raised about staff capacity, to see what staff feels about that. Because in my mind, it doesn't necessarily mean we investigate every single one, but it means we have a really key piece of evidence. If someone's reporting something at a particular location and we see, oh, there isn't a pharmacy tech there, or there is a farm tech there, it's just one key piece of information that our inspectors could be using as they're deciding which places they decide to prioritize looking into. So Anne, what are your thoughts if something like that was to occur, where we ask farm techs to report if they're working in a location that's doing compounding outside of a pharmacy? Do you think that would, what do you think the impact on staff would be for something like that?
Yeah, I think if we're able to partner with DCA, we could probably establish some sort of easy web portal for the notification. So there would be minimal staff, involvement in that piece, because it'll be just kind of managed through an IT solution. And then from that, I think we would have the opportunity to at least understand how frequent the practice is, right? From a data perspective, have that information. But then also we could do some random inspections, not that we're not staffed to do inspections of all these facilities, right? But we could do some random, and similar to how we used a few random inspections, well, not a few, I can't remember how many we did, for surgical clinics, and then the evaluation of those inspections then kind of helped the board inform their policy specific to, establishing and modifying the renewal requirements for surgical clinics. We could then use the data to help inform future policy. So Trevor, I hope I answered your question.
You did, thank you.
Thank you, Anne. Thank you, members. Any other thoughts? All right, next question. Should the board develop educational materials reminding pharmacy technicians of the requirements of USP 797 and federal law related to compounding of drug preparations? I am sure this is an easy yes. Hopefully that this will help educate pharmacy technicians at least. Any other, Renee?
Yeah, I think this is a win-win for all, pharmacy technicians, even ones that are working in licensed facilities, right? I mean, you would just be sending it to all technicians. So this would just be a good reminder to them. I mean, they've, depending on where they are, have already had a lot of training and understand the requirements, but if not, then that's a good way of providing them that information if their workplace is not providing as much materials. So I think it's a great idea.
Thank you, Renee. Okay, we're through our questions. Any final thoughts, members, on this topic? Christine, any lasting words? Anne, anything that you want to share with us?
No, but thank you for the opportunity.
Thank you. Christine?
I would just say any step we make in even going into a few is a step in the right direction. Right now, I don't personally feel like there's any oversight happening at these locations. So I would encourage us to do something.
Thank you. Thank you, Dr. Acosta. I don't know if we have a clear consensus on where we go, but I think where we have consensus is educational materials for technicians. We have definitely educational materials for licensees. If the public ed committee chair Wise is luckily here, if he is agreeable to work with Anne in developing some materials and possibly educating more. Where we might not have clear consensus is about potentially increasing our inspections of these facilities. If members are agreeable, we can try to discuss this issue a little further in our next meetings and kind of decide where we land. And as well as in terms of what actions and what kind of proposals that can be included in sunset that could better protect California consumers who are possibly getting a little high risk medications or products from non-licensed facilities, and what we can do to protect them. Trevor, your hand is raised, and then I'll go to Jesse.
Yes, I'd be interested in seeing if there's consensus on the board for the idea of the reporting of farm techs in outside, because I didn't hear any opposition to it, but I also didn't hear unanimous support of it, because that seems like a tangible next step that's fully within our purview, that takes a step in the direction of getting more of the data. So that's something that I would support. But I just wanted to put that out there if there is an item if that item does have consensus to move forward on.
Sounds good. I do think that is the case. Jesse?
I agree with that. I also think that this is an urgent issue that we really need to address as soon as possible. I think at least my impression is where we lack consensus is kind of like what the next steps down the line are, and just making sure that we are figuring out how to legally get into these facilities without overstepping or anything, but I would be agreeable to some sort of notification. And I guess second to that, when I initially read that notification question, I actually interpreted it as the facility notifying the Board of Pharmacy, not necessarily a technician. So maybe I didn't fully understand it, but I think maybe if we have some clarity, like are we requesting that anyone who has a facility that's performing compounding notify the board, or are we just requesting that pharmacy technicians specifically do a notification? I think that distinction is probably needed as we move forward and as the communications team works on this.
I think that's a great question, Jesse. And for me, ideally, it is the facilities. But as Renee alluded to, that could just be one bag, right? And it could be hundreds. And so maybe some sort of ways to notify the board in some capacity would be ideal, but I think the details of that we might need to ponder about a little bit more. A technician notifying may be a tangible solution, as Trevor said. I do think that that's a one way. Now, there is a question of technicians, we are discussing this legal issue of technicians performing outside of license, and we kind of are alluding that activity may not be legal. So I'm also a little concerned about how all that combines to this question. So not to be wishy-washy, but I have to say I'm a little unclear how we can go. This is why this discussion has not come up for a long time, because I think we are all a little bit uncertain of where we can go or where we should go. And even if we know where we want to go, we're not sure if that's really possible either. So, and I'm going to give you one last opportunity because, actually, Renee, go for it.
Yeah, I just kind of wanted to add in, I would, it sounded like, and I don't know the whole history of it, but the surgical clinics, it sounded like there was concerning practices, and so there were inspections to go and see what they were finding. So then they kind of moved forward with some actions based on the findings. Is that correct? Anyway, it sounded like that. So, I mean, it sounded like, being able to go to some of the facilities to learn more about the compounding practices would be extremely helpful. Although I recognize that I feel like if like somebody on a Board of Pharmacy inspector walked into a medical spa, it probably very incongruent to them and wondering who, what, where, when, what, so again, back to the education.
And back to that point, Renee, would members agreeable for us to at least trying to inspect some facilities just in preparation of our sunset report just so that we have better education. And I think, as Dr. Acosta alluded to already, that they may be already aware of the different standards, but I think it's probably best that we have some clearer understanding. So I'm hoping that that's okay with members. And Trevor, back to you.
Yeah, and following up on that point, I think that's why my mind goes to asking the farm techs to be the ones that report it, because it's much easier to start in a place where you have pre-existing authority versus in a new place where they don't even understand or appreciate your authority. So from just a typical a practical matter, pharmacy techs know who the Board of Pharmacy are. They know the standards we hold in our license to our license and licensees in licensed areas. They understand what it means. Whereas, again, a hangover IV clinic has absolutely no idea about what the Board of Pharmacy represents. And so, my thought of saying, okay, let's start with making sure we just have our licensees who are doing this in outside of a pharmacy area gives us that initial tranche of data to see how pervasive it is. And it provides us a little bit more authority for if/when an inspector does come in, there's a greater recognition and understanding of that authority that the Board of Pharmacy has. And I think it would be a easier first step of dipping the toe in the water of making sure of next steps for this type of regulation. So that was my thought process on having the farm techs be the initial ones to report, and then as a first step, and then kind of take that data and go from there.
Okay. Sounds good. Thank you, Trevor. Thanks for that comment. Jesse?
I actually think that the opposite would be a better approach rather than having the technician self-report. Having the technician self-report does kind of feel like a gotcha situation where the Board of Pharmacy is asking technicians to report themselves essentially on something they shouldn't be doing when they may not be aware of it to begin with. So I think if we're going into facilities, it should just be random or facilities that are reporting the compounding practice so that they can evaluate the standards as a whole rather than targeting individual licensees, at least until the education piece has gone out. That, yeah, which I know gets back to Renee's point of, people or clinics probably going to be a little confused why the Board of Pharmacy is walking into their clinics, but I think just from like an individual licensee standpoint, that may be a better approach so that we're not targeting those technicians individually.
Thank you, Jesse. Renee, and then Jason.
Yeah, again, kind of off of these comments, I also am concerned of relying on technicians to kind of self-report. I mean, and I'll just speak super generally in my little, N of 1 study, but sometimes technicians are not always, ones to be on their email to report. It might be when they have to renew their license. I'm not really sure how that messaging would go out, or how much response there might be, but if there is. But I think there's two things here that are concerning, and I think they're being conflated. But there is the pharmacy technician compounding without a pharmacist's oversight in a non-licensed facility, and then there's non-licensed facilities compounding. So my suspicion in the big picture here is that there's probably a vast majority don't have a pharmacy technician who's compounding. And in fact, maybe like in medical spas, like an MD who can order supplies, an RN is, compounding, possibly like on a higher end one or something. But the point being is that there's probably a majority that don't have a pharmacy technician, a licensed pharmacy technician. So I think it kind of brings it back then to just inspecting some, showing up to see what's there. Because I think also, like, I know it's, we've had a question about, if FDA, asked the state to go in and take a look. I think that's probably few and far between, most likely compared to the number. So I do think going into inspect, however that can be with education, so that they get kind of some kind of heads up that there may be, Board of Pharmacy inspections. I think that's would be a good part of it, but maybe would not be able to preclude it, because really in the end, I don't think people realize how risky this can
Right.
be
Yep.
at all. I think somebody going in to get, a vitamin infusion or something because they're tired, I mean, that's their choice, but there could be such great risk and they have no idea.
Right. Thank you, Renee. Jason?
Yeah, I think I just want to reiterate, I believe of what Jesse and Renee had said, that a little bit of stepping in for a fact-finding kind of mission to see, really ascertain the lay of the land, see what's going on here, and then I think we'll have a better idea of how to move forward.
Sounds good. Thank you, Jason. Thank you, everyone. Thanks for this great discussion on this such complicated topic. So with that, public comment in Sacramento? Any public comment in WebEx? David?
We are open for public comment on WebEx and I believe this is agenda item 10. If you'd like to make a comment, please raise your hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise a hand, and we will call on people in the order we have requests. We also have the Q&A box in the lower right-hand corner where you can type the word comment. And we're going to start with Joe Joliffe. And I believe after that we have call-in user 8. So Joe, I'm going to send you a request to unmute your microphone. You'll be given 3 minutes to speak with a 10-second warning. All right, Joe, it looks like you're unmuted. Are you there?
Great. Yes.
Go ahead, please.
Yeah, I just wanted to, shine some personal light on this, as some experiences that I've had. As I am a pharmacist, and some of these clinics, it's not just the hydration clinics. There's actually robust oncology centers that have immunocompromised patients going to clinics that have just technicians compounding the medications, and they don't have the facilities that are up to date with USP 797 or USP 800. It's potential contamination not only to the technicians that are there, but also to the patients, to the other staff that are there, because it's multi-billion-dollar organizations that have some of these satellite clinics where there may be 20 infusion beds where 20 patients a day are getting those, maybe even more, that are using this loophole of not having a sterile compounding license to be able to administer chemotherapy. So it's not just hangover, it's not just spas, it's really widespread. And I think it'd be eye-opening to the board if they did, some of these inspections about how widespread it is, specifically among cancer centers. And because I've actually have worked with a technician before that did work with one that went to one of these infusion centers. And she was kind of astonished at how, she knew what the standards were. She tried to follow them, but she was reporting to a nurse or to a physician. And again, in a cancer center, that she was overruled for some of those things. So, I know there's a lot of comment about having the technicians try to report some of these things, but they're not the 800-pound gorilla in the room. They're dealing with, very large organizations where, they're just, told what to do, and may not be given the right setup to protect themselves, to meet USP 800 standards. And I know a lot of solutions were kind of discussed, and if I may, just from personal experience, I know for us to be able to order medications, we have to have our pharmacy license valid. And so I think if there are other regulations being evaluated, my pie in the sky ideal would be that Anybody that is ordering any type of injectable medication would have to require a sterile compounding license issued from the Board of Pharmacy to ensure that there is meeting the standards for these types of infusions. In not only the infusion centers, but also in some of these cancer centers and other places where it's very high risk, and I really don't want a
10 seconds.
New England compounding center to be happening in California if we can prevent it. So thank you for the time.
Thank you for the comments, Joe.
Thank you. Next, we're going to have caller 8, followed by Stacy. Hang on just a moment, caller 8. You may need to dial *6 in order to unmute. I'm sending you a request now.
Hi, this is Matt calling from Fresno, California. Hi, can you hear me?
Yes, go ahead, please.
Hi, thanks. Thanks again. I'm really happy to see this as an agenda item. And the caller right before me really, pretty much took exactly what I had to say. I work in licensed pharmacy. We do sterile compounding for cancer-related care, and oh, sorry. Sorry, there's some issue with the phone, but in our locale, we're in kind of a major city here in Fresno, California, and yeah, I just wanted to make the distinction that I heard a lot of the references to these issues were happening in like medical spa or IV hydration clinics, but it really is a common thing. There is a large cancer care facility here associated with a major hospital in Fresno that does exactly that entirely employs pharmacy technicians, and really is unclear if they're following all the current USP 797 and 800 standards. And so, yep, I mean, from a safety standpoint, it's just, for it to happen here in Fresno, and listening to the other caller, I think it is a really widespread issue that really glad to hear that it is being addressed, and also from the standpoint of the technician licensees, they're operating outside of their scope, right? And basically, I know it's not considered dispensing medication, but they're furnishing medication to patients, right? Without the purview of a pharmacist. And, that kind of culture carries over to, when these licensees leave those facilities, we had an encounter with one of those that worked in association with our hospital here, right? And this technician licensee expressed that they were in charge of doing chemotherapy dosing and therapeutic recommendations and things like that. And so it really, number one, it's a huge safety concern, and number two, really kind of undermines the pharmacist, and really largely, exactly like the previous caller said, it really is just these large organizations using a loophole where they don't have to invest, the hundreds of thousands of dollars to $1 million to build a facility that is compliant. They're able to do it without doing all of that. So yeah, I'm thanks again for bringing this up. This is a great topic. Thanks.
Thank you.
All right. Next, we're going to have Stacy, followed by Keith Yoshizuka. Hold on just a moment, Stacy. We're sending you a request to unmute your microphone.
Stacy Neroni, and I just want to say I wholeheartedly agree with the last two callers, and also wanted to know if the board had considered the possibility of maybe focusing in on the personnel licensees that are doing this work is kind of putting the cart before the horse. I think that there's a lot of confusion out there right now in the provider community about whether the locations themselves need and or can obtain pharmacy board clinic licenses. The entities that are able to obtain licenses is a little confusing, and there are some really big gaps in the current pharmacy board rules about who can get one of those clinic permits. And I think that if the board focused more on some education and clarity in that respect, those facilities, a lot of them may come under the board's jurisdiction, and it would solve your problem about whether or not do we just walk into these facilities even though they don't think that we have any jurisdiction over them, or, you know, trying to force our techs to self-report. That we need to take a step back and look at the actual facilities themselves to determine, has the board made it clear who needs a clinic license and who doesn't, and how to get one? Because the exempt from licensure clinics, a lot of the types that are exempt from CDPH clinic licensing are not eligible for the Board of Pharmacy clinic permit. So it leaves this hole as to, well, then what are the rules? What can be done in those facilities or not? And I think that would solve your tech problem as well. So I'd like the board to consider it if of course you haven't already done so. Thanks.
Thanks for the comments.
All right, next we have Keith Yoshizuka, followed by Stephen Gray. All right, Keith, bear with me just a moment.
Thank you for the opportunity. I want to applaud the board for the direction it's taking on this issue. What I wanted to raise was a possible chilling effect. I think Renee Barker identified it on the button. What I don't want to happen is to discourage pharmacy technicians from getting involved here, from being hired at a clinic as a medical assistant, because I would rather have somebody in there doing these functions that has some training, as opposed to just having a regular medical assistant compounding these things. And if that chilling effect were to occur, and the perception was that we were discouraging pharmacy technicians from performing these functions, I think it would place the public at a higher risk by having folks that absolutely had no training. The analogy is like if you were hiring a software programmer to do a pharmacy program. Several of these software companies hire pharmacy technicians. They're not performing in a pharmacy, but their training allows them to do their job effectively. So again, I think the board is headed in the right direction. I just worry that it might be perceived that the board is trying to discourage use of pharmacy technicians in these venues. Thank you.
Thank you, Dr. Yoshizuka.
Next, we're going to hear from Stephen Gray. Hold on just a moment. We're sending you a request to unmute your microphone.
Thank you. I really think you're headed in the right direction. I appreciate this. We've been actually thinking that it should go that way, not only for the compounding issue, but for the drug storage issues that are out of control and a danger to the public in these facilities. It all starts with making sure you understand the law. The federal law says that physicians and pharmacists can compound. That's it, closed. State law may expand that. Interestingly enough, under California law, there's nothing in the statute that says that technicians can compound. It doesn't use that word. 4051 says, except as otherwise provided in this chapter, it is unlawful for any person to manufacture, etc., other than a manufacture, compound, furnish, sell, dispense, other than a pharmacist. What you look in the regulations, technicians do not do compounding. They do, quote, mixing and packaging under the direction of a pharmacist. So compounding is a higher level of decision-making. The master formula, all of that stuff has to be done by a pharmacist. A good issue is raised that are these facilities operating illegally? How do they get their dangerous drugs? How do they get a wholesaler or a manufacturer to give them IVs? Those are prescription dangerous drugs, and the things that go in them may also be dangerous drugs. The Board of Nursing already chastised dialysis facilities for allowing registered nurses to compound anything that wasn't immediately administered. And they had at one time, maybe still do on their website, an admonition and a reminder to all registered nurses that they cannot compound peritoneal dialysis solutions with heparin, vitamins, antibiotics, and things in them to be dispensed to the patient to get them through 3 or 4 weeks until they come back to the dialysis clinic. So it gets down to, how do they get their drugs? Many of these facilities, these clinics, are under the auspices of a physician. They're using the physician's license to buy drugs, hopefully checked out by the wholesaler and the manufacturer, and they're shipping them to them. But others are not, and they're just getting them somehow. So that, and there needs to be a real good discussion with the medical board in California about to whom can the physician delegate compounding. It was just mentioned, for an example, that a lot of physicians think they can delegate anything they want to anybody they want to. And they do delegate to MAs. MAs cannot work in a hospital. They can only work outside of a hospital in a medical office or clinic environment. And they do delegate some of these compounding activities to MAs or other
10 seconds.
Certified. And also beware that when challenged, some of them have been told by their employers, just give up your pharmacy technician license and then it's legal.
Time.
We'll go from there. Thank you.
Thank you, Dr. Gray. Thanks for the comment.
And those are all of our requests for comments.
Thank you, David. All right. Thank you for all the comments. Lots to digest as expected. But of course, we don't shy away from controversial topics, as always. We'll keep you all posted next meeting of what more to come on this issue. Thanks for the comments. Next, we're moving on to the agenda item 11, presentations on central fill pharmacy models. We are excited to continue our discussion today on the central fill pharmacies, as was suggested at the January 2024 meeting. We're going to receive presentations from representatives of 2 companies that currently use central fill model. I would like to thank both presenters in advance for your time, preparation, and willingness to present before committee today. We look forward to learning about your models. First is Rob Geddes, Director of Pharmacy, Legislative, and Regulatory Affairs with Albertsons. Rob, the floor is yours. Thank you for coming.
Thank you, Board President Sung and members of the committee. I'm happy to be here with you. As Sung introduced me, I am the Director of Pharmacy, Legislative, and Regulatory Affairs for Albertsons Companies. We do operate approximately 370 pharmacies in the state of California under multiple different banner names. So as Anne reached out to me and asked if I would be willing to provide some education on this topic, I was really happy to do so. We can go ahead and move to the next slide. I don't have a whole lot of slides and information, so happy to answer questions as they come, but I wanted to just kind of keep it more high level to talk about what is central fill, how is it leveraged, and what are some of the benefits associated with it. So as indicated in the current regulations in California, central fill, it really is a shared service between 2 licensed pharmacies, and it can be set up 2 different ways. One, it can be commonly owned pharmacies, so the same owner owns both facilities, or there can be a third-party contract where one pharmacy provides this service to the other, really just as a third-party service, not necessarily under that ownership structure. These are highly automated facilities. In general, they service hundreds of pharmacies across a large geography. We currently have one central fill facility that is located in Richfield, Washington, just outside of Vancouver, Washington. And that location is licensed in Washington, Idaho, and Oregon, and is servicing pharmacies across all 3 states. So these are the reason for that. They have the ability to do high capacity volume. So one facility can service multiple locations, but it also allows an owner of pharmacies to control inventory costs, leverage economies of scale. But really the purpose that we've been implementing this, and just to be in full transparency, we opened this facility late in 2023. and have just gone to full capacity more recently as we've been able to finish the full build out of the facility. So prior to using that location, we did leverage in several locations a central fill to service. So Albertsons has had experience with both models, common ownership as well as the third party service that we had a contract with. In any event, the reason that we started to use central fill was to help offload some work and tasks that can be removed from the pharmacy to allow those who are in the pharmacy to focus more specifically on patient care and patient-facing tasks that require that pharmacist's attention, the technician's attention as well. Couple of things just before I move into the next slide. A couple of important definitions to kind of draw a distinction as you're looking at central fill. You do have these two different pharmacies, whether it's one pharmacy that's servicing hundreds of other pharmacies. In any event, the relationship between the two different pharmacies that interact with one prescription is one is considered the dispensing pharmacy. That's the one that ultimately receives the prescription directly from the patient or prescriber and will dispense that prescription at the end of the day to the patient for their ultimate use. And then the other one would be the central fill facility where the physical filling of the prescription takes place and is sent back to that local or dispensing pharmacy. On the next slide, if you want to move to the next one, I'll get into what I wanted to do is just kind of cover in high level what are the responsibilities in our model at each pharmacy and how does that prescription actually flow. So it always starts with the dispensing pharmacy. They receive that prescription from the prescriber or the patient, whether they bring it in or if it gets sent in electronically. The data entry, the adjudication of the prescription occurs. A pharmacist does the data verification to make sure that it was entered correctly, and then performs the drug utilization review to make sure the medication is appropriate for the patient. Once all of that has occurred in our model, that is when this prescription can be eligible to be sent to the central fill facility for fulfillment. The way that this does work is the system between the two pharmacies does have the ability to communicate. Some prescriptions will automatically send, others can be manually sent by the associates working in our pharmacies. But in general, it does have to meet certain criteria to be eligible to be filled in a central fill environment. One, it has to be a future dated prescription. So the expectation would be the patient is planning to pick this prescription up far enough in the future that we have time for that fulfillment to occur and then the prescription to arrive back at the pharmacy in time for the patient to pick it up. The medication also needs to be on the formulary of the central fill facility. We don't carry every medication. So as an example, our facility, we do not do any controlled substances in this facility. We don't do any refrigerated items either. In general, most of the prescriptions that do go through the central fill model would be items that have been placed on automatic refill, giving us much needed lead time in order to get that to and from the central fill facility, or prescriptions that a patient calls in and leaving the expectation that they're not going to be picking it up for a few days. Once the prescription does arrive at central fill and that central fill facility receives the notification to fill a prescription, it goes through the automation or manual filling. The majority goes through automated filling, and I'll show pictures on another slide that just kind of demonstrates the type of automation that we do have in these facilities. But as I mentioned before, highly automated, using counting machines that will count, label, and apply the cap to the medication and move it right along. Other medications may require manual filling, maybe a medication that's not suitable to be placed inside of automated counting devices, or it just doesn't make sense, not enough volume, but still something that we keep in the formulary. Once the medication has been counted through either a manual or an automated process, it does get sorted into a tote, packaged with the paperwork that it needs, and then that tote is ultimately routed back to the dispensing pharmacy where the patient will ultimately be able to receive that prescription. Once it comes back from the central fill facility, the dispensing pharmacy, they do receive a tote, generally with a few to 100 prescriptions, depending on the volume of the pharmacy. and they check these in, and then they place them just in their will call, ready for the patient to be able to pick that medication up. At this point, it's treated like a normal prescription, whether any other prescription that may have been filled locally versus going through the central fill process. And when the patient arrives for pickup, the patient has the opportunity for counseling being provided by a pharmacist. The payment is collected same as any other prescription, other than the associates inside that facility knowing that it's gone through central fill. In some cases, the patient may not be aware that it did have that. So depending on the state, in some states we're required to notify the patient that central fill has been a part of the process, but that is really kind of state by state dependent. Most states have some kind of a notification requirement that a patient needs to be aware that their prescription may go through that filling process. So if we want to go to the next one, these are really just two pictures to describe or just to kind of show. The picture on the left, this is one of the automated filling devices, and each of those, you can see the robotic arm that's yellow. That's what's going to move the vial around, make sure that it gets filled, takes it from the filling device to put it back onto a conveyor belt to go through the next steps of being packaged and shipped back to the store. These are considered canister devices or they're called dispensers, and then they have a bulk canister on top that the medication is moved into. Prior to being loaded in the machine, a pharmacist has to verify that the correct medication was loaded into the canister. Highly sophisticated barcode scanning and validation processes occur to make sure that the appropriate canister is loaded to the expected dispenser so that it makes sure that the right medication will be ultimately filled for the patient. On the right-hand side, this is just an example of, it's called the Thompson sorting device. And these little yellow, they look like Tonka trucks, if anybody had a Tonka truck back in the day. You can see the individual right there is scanning a prescription where it's glowing in red next to her right hand. That scans it, it gets put into one of these little trucks, and then it routes itself to the appropriate tote that is designated for the store that's ultimately going to receive that. So we have lots of different automated processes within this facility that helps us to be able to process thousands of prescriptions in a day to get them back to pharmacies, and thus remove some of that workload so that the patients can have the attention of the pharmacist and the technician when they are in front of them at the counter. We do believe that central fill provides a great benefit. As we've been getting into this a little bit deeper and deeper, as the stores have been loaded onto it, they've been extremely appreciative of it. In the Northwest, so in Washington and Oregon, those have been areas where we have really experienced a lot of challenges in hard to staff areas, and this predates the pandemic. Back when I worked in Oregon, it's always historically been a hard place to staff. So this has helped us in areas where we may not just even have the bodies to do some of the work that needs to be done. So it's helping replace some of that work that just can't be acquired through the typical hiring process to allow us to meet the needs of the patients and still provide pharmacy access in some of those areas where it's been historically challenging to hire associates. So we would encourage the board, as you go through this process, to thoughtfully weigh the support that pharmacies need today and the innovative approaches that companies are working on employing in order to support those pharmacies, as we know that there's many challenges in the workplace today. And this is one of many solutions that Albertsons is employing right now to help support our pharmacies in a more full capacity and allow our patients to continue to have a great experience as they visit their pharmacists and their technicians at the pharmacy. So those are the few things that I wanted to just share from a real high level approach. I'm happy to stand for any questions the board may have at this point.
Thank you, Dr. Geddes. Really appreciate your time. Members, any questions for Dr. Geddes? Jesse, and then Trevor.
Yeah, thank you so much for the presentation. I know that you mentioned that that Albertsons, I say we because I work for Albertsons, sorry, uses central fill. It sounds like primarily in other states. Does Albertsons currently utilize it within California?
We have a small number of stores that we use the central fill as a service at this point. So we have a licensed pharmacy that's located outside of the state that does assist. I think it's less than 10 stores that are currently on that service. So very select areas that that needed the support at this point.
Got it. Okay, thank you.
Yeah, you're welcome.
Thank you. Trevor?
Yeah, just I was curious, have you all done a study on medication errors through central fill versus typical pharmacist fill? Because I noticed that you had a lot of quality controls once the pills were in the container and then being shipped out. So I'm wondering what kind of checks are there to make sure that the right medications are going into the right container in the first place and that sort of thing.
Great question. So backing up a step, there's several safety checks and balances in place to make sure that the right medication makes it into the canister to begin with. Everything similar to other pharmacies is really rooted in following stringent SOPs to make sure that the right things are happening and nobody's circumventing or cutting corners that would result in potential patient harm. So some of those safety checks and balances are really ingrained within the systems that we're using. So for example, when a technician is going to fill a canister with medication to replenish one of the robotic machines, they have to scan each and every bottle that goes in. If for some reason one of those barcodes does not match, the entire system locks up, like the canister itself gets locked to the device that it's slid into until a pharmacist is able to come over and validate and correct whatever may have gone wrong. So that's one check and balance where we're using the barcode scanning. The dispenser and the canister, so that the top and the bottom of these counting devices electronically communicate. And if the door between the time that the pharmacist verifies it and it gets loaded into the robot, if the door to that drops the medication into the dispenser has been opened, or otherwise potentially tampered with, it's able to recognize that unauthorized opening has occurred, and it will lock and not allow any medication to be dispensed until, again, a pharmacist clears up any concerns that might arise from that. So that's kind of some of just there's other checks and balances, but for sake of time, I'll jump into the other side of it. So we do have routine quality assurance audits that occur. So about 2% of the prescriptions that get filled through this canister and robotic automation do get routed for pharmacists to manually verify. So again, through the process of that canister being used to fill these prescriptions, the pharmacist has eyes on a percentage of those prescriptions to make sure that they've been filled appropriately, and just looking for any instances where something may have not gone appropriately according to the policies and procedures. There's also specific count audits that occur to verify the accuracy of the counting itself, just the quantity. So they get routed to a technician to verify the quantity to make sure that it matches what was expected to be in the bottle. And if it doesn't match, it requires the pharmacist, again, their attention to resolve any matter. So those are a few of the things that we employ from a routine quality assurance standpoint in order to make sure that everything is staying safe. In the time that we've had, so we've had this facility operational for approximately 6 months, a little over 6 months. We've not had any instances that we've identified where the wrong medication has made it to the patient. And so in our opinion, the safety checks and balances that are built into the processes and systems are very well designed. In fact, probably safer than having humans counting it manually like they do traditionally in a pharmacy, making sure that we have that in place. So hopefully that answered your question, Trevor. If not, I can go a little different direction if you need to.
Thank you, Rob.
Question,
Renee?
Hi, yes. A couple of questions. One for you is, can you elaborate a little bit on kind of what, without super specifics, but what is the determination for when you said a store needs some central fill support?
Yeah, so we do it based on an algorithm that helps us determine from a volume standpoint, also proximity to where they can get the support. So the model that we use we use our wholesaler to bring the medications back to the pharmacy. And so if a pharmacy, so for example, there are stores in Idaho that aren't supported on central fill that otherwise would meet the criteria to be supported, only because the distribution center with our wholesaler that they use is not in close enough proximity to get it to there in the time frame that we need to in order to fulfill the needs of the patient. But there's other criteria. So our operations team, if for example a store has a significant staffing crisis, we're able to load them on central fill either permanently or temporarily until the staffing crisis has been resolved. So being able to give them support in times of need, or in the more common route that their volume necessitates the need to have the support with central fill. So those are kind of some of the different things that we look at to evaluate which stores should be put on and which stores shouldn't. The ideal world would be that every store would have the support. It's just a stepwise approach, and we're still actually in the implementation phase of rolling more and more stores onto it to achieve full capacity. The way these facilities are designed, they usually run by shift, and so for the facility in Washington, it can do approximately 20,000 prescriptions in a shift. And we have the ability someday to do a full 24-hour cycle. So you could have 3 shifts running in a 24-hour period. Right now we run just 2 shifts. So we do have the ability to ramp up capacity at a later date as needs present.
Okay. And then my second question, thank you, was just looking at your steps. So when the prescription makes it back to the dispensing pharmacy from the central fill pharmacy, you have that the prescriptions are checked in, the patient is notified, and they arrive at the pharmacy, and then presumably then that, consult with the pharmacist. But I'm just wondering if there's any check by the dispensing pharmacist when the med is returned. I know this has kind of been something that's been discussed.
Right.
And
Yeah.
if you do or you don't, and then you don't have it in there, so I'm assuming you don't. If you don't, then what was that decision?
Yep.
How was that made?
So we do not. So yeah, you picked up on that correctly. We do not have a required check. The check-in process is checking in the bulk prescriptions that are coming from central fill, then filing them into the will call, so it acknowledges to our dispensing system that the prescription has arrived, and that kicks off the notification to the patient. The reason that we have not is these facilities are mutually licensed within the state where that prescription is being dispensed. And so we view this as a corresponding responsibility. Each step in the process is task tracked. So we know who is responsible for identifying that the right medication was loaded into a canister, therefore being responsible for any prescriptions that are filled from that canister going forward. And so similar to a pharmacist having their eyes on the prescription in a store that's filled manually in that store, that pharmacist who is the last one to verify the medication was filled correctly is the one that's responsible. In a situation like this, that would still hold true, in our opinion, and the states where we have rolled it out, that's been allowed, where that shared responsibility between 2 facilities based on which steps occur where and by whom are employed in that type of fashion. So that is the way that I would say is most common across the country, is whichever pharmacy does the step, whether it's the dispensing pharmacy that's doing the drug utilization review to make sure that the correct medication for the patient is being entered at the beginning of the process, or the pharmacist in the central fill facility that's responsible that the right medication got filled. We don't view it necessary to duplicate that step once it's returned to the pharmacy.
Was there in this process, like in a new pharmacy that's beginning to get, prescriptions from the central fill, was there any discussion? Does some pharmacists want to be able to check it? I don't know how they
We
or
don't.
could they, if let's say somebody really wanted to,
Yeah.
what's available to them?
They could if they would like. They certainly can. We don't prohibit them from doing that. It's just not a step that we would require them to do. We do believe that the processes and systems that we're using in these central fill facilities are safe and accurate to the point where we don't feel the need to encourage people to have that type of behavior. But I can tell you that in the beginning phases, there are pharmacists that do feel the need to check it, and likely continue to do so until they have the confidence in the process that they no longer feel the need to do that.
Mhm. Yeah, thank you so much. Appreciate
You're
your
welcome. Great
your
questions.
answers. Thanks.
Thank you, Renee. Jesse, your hand was up. Was it not? Okay, you're good. Okay, Jason.
Thanks for this presentation, Rob. It's very informative. Can you tell me, I think that you said that one location in the Pacific Northwest filled 20,000 prescriptions in a day. How much does an average Albertsons usually fill in a day?
Yeah, so good question. So that's the maximum capacity that they have that they can do in a shift. So if they ran 3 shifts, they could potentially do 60,000 prescriptions in a 24-hour period. Our average across the board, when you look at total company, is around 1,000 prescriptions, maybe 1,200 prescriptions a week. So that normally we're not hitting the volume where approximately 30% of a prescription, when they're fully optimizing central fill, 30% of the prescriptions that a pharmacy is filling would go through a central fill process. So it's not taking everything out of that pharmacy. It's really looking at the maintenance chronic medications that are on automated pre-fill that can be gone through this manner. But the facility and kind of the point of the maximum capacity is that they have a lot of bandwidth to be able to support many pharmacies. And so when we look at placing central fill in a certain area, we're looking at what's the optimal location from both wholesaler proximity, but also to maximum number of pharmacies that it could potentially service. And so I know one of the things that's been discussed previously is having this limited to inside the state of California. I think that would be something that we would encourage the board to reconsider and steer away from, because it does limit the ability to make sure that all of the components that need to be in place for a pharmacy, central fill pharmacy, to be able to service these pharmacies may not always be in the appropriate location where our pharmacies are. So for example, if we were to service California, we may end up putting the pharmacy in Nevada in close proximity to where we could service multiple states from that central location. Just things to consider, that the support that pharmacies need today is pretty great. And we're trying to balance multiple things where we're taking care of the needs of the pharmacy staff, but also making sure that we can optimize the use of a facility that's a large investment for the company, so that it's not underutilized if it's doesn't have access to the appropriate amount of pharmacies or the appropriate amount of prescriptions per se, that it has the capacity to help fill.
Okay, thank you. And maybe if you could, for me, I don't know if you can answer this question or not. On the question of the final check, there's the originating pharmacy, then the central fill pharmacy, and then it says to come back, and there is not that secondary check. So when you have a direct to consumer mail medications, is there any difference between how the central fill operation works as to the direct to consumer operation?
It is different. So we don't do a direct to consumer. So this is going to be more, I'll talk to you more in general principles, but when you're using a central fill model that's going back through a pharmacy, it is going to be regulated from a slightly different perspective than if you are going direct to the consumer. The reason is that if you go direct to the consumer, there's going to be different labeling requirements, because now you're no longer dispensing it from the pharmacy where the patient was expecting it to come from. It's coming from ultimately a different pharmacy. So there would be a need to have acknowledgement to that patient that this pharmacy is the one that's responsible for filling that prescription for you. So it is a slightly different model. I would say that there's very similar technology leverage by both a mail order and a central fill facility to process high capacity, high number of prescriptions. But I wouldn't lump the two together, because they are ultimately a different business model that would be subject to different regulatory requirements, from labeling, counseling, being available to the customer for questions and the like.
Thank you.
You're welcome.
You, Jesse, back to you.
Thank you. I do have a follow-up question, and I'm not sure if you even have the answers to them, but do you know how the volume in the California locations you have compared to the other states that you service more?
On average, they're lower volume. I don't have the exact number how they would compare, but I do know from anecdotal that our California facilities are generally lower. We have pharmacies across the country that do more than 4,000 a week, and then we have some that do 200 to 300 a week. So quite a large variation across different geographies, and of course that is very dependent on, are they in a remote location, only option for a city, things like that. But our California locations are not as high volume as some of the other parts of the country. Illinois and Idaho are our highest volume, and then also Washington and Oregon fall into that. Those are probably the highest areas in the country.
Okay, so then it would make sense then that there's only 10 or so stores that you actually service through the central fill model.
Yeah.
in California.
And the reason being, just one other thing, with it coming from a third party, when you're talking about a third party contract, we aren't able to leverage the same distribution model. So it's coming through FedEx to a location, and that's just a little different cost profile. So it has to really make a little bit more sense. That is it more expensive to provide this service than doing it locally with the manual processes that are employed today. So that's the kind of the limiting factor. Having dedicated resources that can use the distribution networks that are built in really make it more feasible to supply to a larger number of pharmacies in a given geography.
Great, thank you.
You're welcome.
Thank you, Rob. Thank you, everyone, for your wonderful questions. So with that, we're going to move on to the public comment. Rob, as public agency, we do provide the members of the public the opportunity to comment on each agenda item. This is not intended to be a question and answer, but you are more than welcome to answer.
Sure.
Nobody is in Sacramento, so we're going to go for WebEx. David?
All right, we are open for public comment via WebEx on the presentation that was just given. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise a hand, and we will call on people in the order we have requests. You may also use the Q&A function and type the word comment into the Q&A box. Send that comment to all participants. Speaking of which, we're going to start with Sean O'Rourke, who has put in his request a while ago. Hang on, Sean. We're going to send you a request to unmute your microphone. And I'm looking at Sean, and it looks like you do not have a good connection. Perhaps you don't even have a microphone connected to your setup. So we're going to skip you for a moment. Hopefully we can give you some suggestions to figure out your side of the thing. In the meantime, let's move on to Sarah. Sarah Polomu. Bear with me just a moment. We're going to send you a request to unmute your microphone. All right, Sarah, I see that you're unmuted. Are you with us?
Yeah, can you hear me?
Yes, go ahead, please.
Awesome, thank you. Sarah Polomu with the California Community Pharmacy Coalition. We thank the committee for discussing this issue in January and appreciate the presentation from Albertsons. We've reviewed the draft language and remain concerned about some of the provisions. Generally speaking, we want to ensure central fill is not limited or restricted and avoid differential requirements state by state. Specifically, the language in subsection A, limiting central fill to pharmacies that are located within California. This would be highly problematic for our members and limit drug fulfillment operations in California. We would request specific language specifying that central fill is permitted both within and outside of California by California licensed pharmacies. With respect to final verification, the draft language specifies that pharmacists working at the originating pharmacy must perform final product verification prior to dispensing. As we stated at the prior licensing committee meeting, We request that this language be modified because requiring verification at a dispensing pharmacy takes away much of the usefulness of central fill, even if it's being done by reviewing photographs. We respectfully suggest that this language be modified to preserve this practice and avoid adding additional duties that hinder pharmacy workflow. Thank you so much.
The comment, Sarah.
All right, thank you. Next, we have Sean O'Rourke. We're going to cycle back to you. I've got some visuals on the screen. Hopefully that can help you figure out what's going on with your audio connection.
In the interest of time, David, I'm going to move on.
Absolutely.
If Mr. Sean can come back after Lori's presentation, I'm more than happy to entertain his comments. So we're going to move on. Thanks, Rob. I really appreciate it. Hang around, please.
Thank
I'm
you very
sure,
much.
So next is Lori. Lori is Director of Pharmacy Affairs with Walgreens. Lori, the floor is yours. Are you ready? See the slides up.
Yes, I am.
Waiting
Thanks.
patiently the whole day. Thank you. Thanks
Thank
for
you so
enduring
much.
through our meeting.
Thank you so much. Really appreciate it. Again, good afternoon, board members. My name is Lori Walmsley. I'm Director of Pharmacy Affairs for Walgreens. I appreciate the board providing me some time to discuss our central fill models in an effort to educate the board members as you continue on with your policy discussions on this important topic. If you could move to the next slide, please. Our central fill model is one tool that Walgreens uses as an effort to balance the workload for our in-store team members, allowing them more time to focus on high-touch patient experiences by removing some of our filling workload from the community pharmacies. We repurpose all of the time for the tasks that are spent from the removal of the filling tasks by allowing technicians in our community pharmacies to spend more time on clinical functions like immunizations, testing, prescribing therapies like hormonal contraceptives, PEP and PrEP, like discussed earlier today, and counseling. In the states that we have implemented our central fill operations, we have removed no labor from our community pharmacies. We're simply using that labor as an opportunity to repurpose that for the purposes of clinical activities in our pharmacies. If you could move forward to the next slide. Walgreens is a leader in this space and has significant experience with central fill operations, and we've made huge investments over the last few years to support our team members and patients using this technology. Our oldest central fill pharmacy is located in Phoenix, Arizona, and has been in operation for just over 3 years. In the period of time of 3 years, we now have 11 central fill pharmacies across the United States. Those are indicated by the current red stars on the map. And we support 32 states across the United States using this technology with a plan to implement additional sites later this year and beyond. Currently, approximately 40% of our prescription volume filled in the states that receive central fill services are filled out of these facilities. If you can move forward to the next slide. I will go through the workflow for our central fill pharmacies. It's very similar to what Albertsons covered, but I will highlight a couple of differences. And I think that the way that this is displayed on the screen might be a little bit easier for some of the members to see. Specifically, Executive Officer Sodergren asked that we spend a little time walking through what's done in each of the facilities. So I'll orient you to the slide here a little bit. The first row of boxes on the top, or the first swim lane, illustrates the functions that are performed in the traditional community pharmacy. The middle swim lane is the activities that are completed in our central fill pharmacies. And then the bottom swim lane, again, are activities that are completed in a traditional community pharmacy. When you talk about the way that a prescription is initiated, they're initiated in the same way that they are today. A new prescription can either be dropped off, it can be phoned in, it can be sent electronically, or a refill can be generated in any number of ways that it currently is today. In order for a prescription to be centrally filled, a couple of things need to happen. First off, it needs to have a pickup time that can be met by the central fill pharmacy to be eligible. Generally speaking, that is the next day. And then secondly, it needs to be in the central fills pharmacy inventory or formulary, similar to what Albertson spoke about. Our central fill pharmacies also do not carry controlled substances today, and we don't stock every medication. Typically, the medications that are filled in our central fill pharmacies are things of that have a little bit of a lead time, so usually a day or more, because pharmacies will receive their central fill deliveries the next day. And things that are routine in nature, things like blood pressure medications, cholesterol medications, those types of things, or medications that are low moving inventory that can be more effectively utilized by pharmacies, being held at a centralized location and being dispensed out through the central fill model. So it helps to address some cost concerns with inventory carrying costs for pharmacies, but it also helps to maintain inventory so that you can prevent drug shortages and those kinds of things, because all the inventory is held centrally. We do stock refrigerated products at our central fill pharmacies, unlike Albertsons, and those medications, as they're sent out to the local community pharmacies, are packed in the exact same manner that the wholesaler packs the product. And I'll talk about the kind of the distribution method as we move forward in the process. When you look at the activities that occur in the first swim lane, as I said, the prescription is generated the way that it normally is. In the case of a new prescription, it is entered by a pharmacy technician or a pharmacy clerk. In the case of California, it could be by one of the team members in the local community pharmacy. From there, a local pharmacist in the local community store would perform data review and clinical review before the prescription can be routed if it's within the pharmacy's, the central fill pharmacy's inventory. So an upfront verification is occurring prior to the prescription being transmitted electronically using a shared common database between the two pharmacies. Another critical component is these prescriptions are also free from any third-party exceptions on the prescription. So these are prescriptions that we are fairly certain that a patient is going to pick up. So it wouldn't be anything that wasn't covered by the patient's insurance or any of those kinds of things. Those items wouldn't go to the central fill pharmacy to be filled until those exceptions were cleared up. At that point, the prescription is electronically in a shared common database sent to the central fill pharmacy to be filled. Similar automation as to what it looks like Albertsons does. The majority of the prescriptions that are filled in a central fill pharmacy are being filled through automation. Similar to Albertsons, this is highly sophisticated robotics using a closed loop filling system with multiple steps of checks and balances using technology data points to prevent errors, but it's ultimately checked by a pharmacist in the facility before the prescription is packed and sent to the local community pharmacy through automation. The other version of filling that occurs in the central fill pharmacy is manual fill products. Those prescriptions are filled by technicians in the facility using imaging technology, so barcode technology, to make sure that it's the right prescription for the right patient, the right barcode, and then the pharmacist will check that. Items that are filled traditionally from a manual fill process are things like inhalers, creams, those types of things, unit of use products, things that wouldn't necessarily be counted on a per tablet or per capsule basis. Once the prescriptions are filled, they move through the facility where they're ultimately packaged in the facility using robotic technology to ensure that the right labeling, packaging, etc. is in there. And then the prescriptions are separated by local community pharmacy for the courier to pick up. The prescriptions are sealed into totes and delivered the next day with the community pharmacy's inventory using the local fulfillment replenishment wholesaler, AmerisourceBergen, using the already existing distribution system. So sounds like similar to what Albertsons does. Once the prescriptions are received by the pharmacy, as I stated, they are in sealed totes that have an exterior label and a manifest that includes information as to each prescription that is within the tote. The tote is scanned, which would then trigger the notifications to the patient by whatever means that the patient wishes. So whether that be text messaging, emailing, phone calls, however the patient has their communication preferences. The prescriptions are checked in and put into the waiting bins. And then are ready for the patient to pick up. The prescriptions are counseled just like they are today by a community pharmacist. So I guess one critical piece again is a pharmacist is responsible for checking the accuracy of the product within the facility, so that process is not redone once it has arrived in the community pharmacy. Actually opening the packages could potentially introduce a potential for errors because those packages have been put through the robotic systems to ensure that they're from a barcode scanning perspective that they are accurate, etc. before they end up in the pharmacy. If you can move forward to the next slide, please. Albertsons mentioned this, and I apologize, it's kind of small on the screen, so I hope that you received these before the meeting. Albertsons mentioned that they have trackability to each point in the process. This is a copy of our record keeping that is available for central fill, similar to what we have in our pharmacies today, but it would show each of the activities that occurred within the process. So where it occurred, who did each of the processes, how it was filled in the facility, and you can track that for each and every patient. So we would know exactly who checked each portion of the prescription from an auditability and accountability standpoint. So this is maintained for both the robotic filled medications and the automated products. So this is an example of one that did not come through automation. And if you could move to the next slide, this would talk. I'm sorry. This second one is the manual fill. The one that has automation on the prior screen does show that it was filled through automation and robotics as well. So just so you guys have an idea of what the documentation looks like, that you would be able to see that throughout the entire process. And I will pause there for questions.
Thank you, Lori. Members, any questions for Lori? Jesse?
Hi, thank you, Lori. My question, similar to the Albertsons presentation, do you know how many pharmacies you service within California, or do you currently service any pharmacies in California?
We do not service any pharmacies in California. If you looked at the map that was on the screen, we do have 2 locations that we would like to open in California. Today, we do not service any pharmacies within the state of California. Similarly to Albertsons, our routes that are in terms of service are based on our wholesale distribution schedule. So that way, we're not adding to the carbon footprint, any of those kinds of things that comes automatically with the other drugs that the pharmacy would be getting. So replenishment for drugs that they filled in the pharmacy, and then the pre-sealed, pre-packaged inventory for the medications that had the lead time for patients. But today we don't service at all in California.
Great. I think I had a second question, but I forgot, so I'll get back to you.
Okay.
Any other member comments or questions for Lori?
Well, actually, Sung, I remembered.
Yay.
Sorry. Does Walgreens have a similar method of determining like the appropriate pharmacies? And then a follow-up to that, do you know how the volume of prescriptions filled in California compares to the rest of the country?
So our goal is to service all of our pharmacies. As I mentioned, we currently service 32 states. Every pharmacy that is within that distribution center and the central fill pharmacies I guess delivery route would be included. It doesn't really matter the volume of the pharmacy. This is one strategy that we have as a company in terms of an investment to make sure that we're able to support our team members to be able to perform our clinical functions. So we don't look at it as a per volume type basis. It's really just a matter of the distribution schedule, the distribution network that exists today. In terms of volume within our community pharmacies, I'm sorry, I'm not able to speak on that today. I wasn't prepared to do that. I can certainly get back to you, but I don't have where California compares to the rest of the country.
Oh, no, I don't think that's necessary if the determination isn't a volume based.
No, not at all.
Perfect. Thank you.
Thank you, Jesse. Thank you, Lori. I'm going to open up for public comment in this case. Lori, just same thing for you. You don't have to answer, but you are welcome to if you are asked the question. And I don't think anyone is in Sacramento, so we're going to go for WebEx. David?
We are open for public comment on Lori's presentation. If you would like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial in user style *3 to raise a hand. And as a reminder to our mobile device users, if you're having trouble finding that hand button, please hit the ellipses button, the ... at the bottom. We're going to take just a few seconds to see if we have a request for public comment. Seeing no request for public comment, do you wish to continue?
Sure. Thank you, David. Thank you, Lori. Thank you, Rob. Again, I really appreciate you guys coming on. And it is 3:17, so it's the right time to take a little break. But before we go on, I just want to survey members. Next agenda item is item 12, which we are actually discussing the regulation and seeing if we might have consensus on it. Just wanted to survey from what you heard today. Do you feel like you have enough information for us to tackle this regulation today? Or do you need more information? Just kind of, I don't want us to but spend a lot of time if we're not going to be able to land somewhere. So just kind of wanted to see if you guys need more information or if you think you have enough information for us to try to.
Well, Sung, this is Jesse. Outside of the presentations that we received today, did we receive any information about some of the other companies that may be utilizing a central fill service within California? In terms of like the number of pharmacies serviced or?
Yeah, I think I would have preferred a little more information as what I got from last meeting was there were a lot more. And then I think we weren't able to have them come present today. So, Anne, do you want to speak on that?
Yeah, so a couple of companies advised that they were unable to present today. We did receive from one company that has indicated they would be willing to, but it was after the agenda was released. So we do think that there's at least one other company that would be agreeable to providing a presentation, but we received, declines from others in response to the invitation.
Okay, I would say my impression, Sung, also from the last meeting is that I was under the impression that this central fill process was on a much larger scale, just given the reaction from some of the companies. And so without having more information about the specific numbers and the pharmacies and the number of communities that are going to be affected, I'm not sure if I have enough information just yet personally.
Okay. Renee, Jason, Trevor.
So I'm happy to be party 3 on holding off on this.
Okay. All right. Renee?
Yeah, I feel the same way that Jessica was kind of describing. As I think we just heard 2 great presentations, and it's good to, we got an idea of what central fill is, the operations of that. But again, I think one of the big questions and that we were hearing is, located in California. So in both these cases, that's not really true. I'd like to hear from some places that have, maybe some extensive central fill into California.
Yeah,
I'm
and
assuming there are some, and find out who's doing, what does that mean?
Right.
Yeah.
Well, and our next agenda item 13 discusses the concerns that were raised by non-resident pharmacies that we are coming across. So I will personally say that I feel extremely uncomfortable opening this up to non-California pharmacies. I'll just say that. I do think that there has to be some guardrails as we are coming across some non-resident pharmacies. And I don't think that it's just a solution for us to just let everything just across the border and hope that it's gonna just be okay. I do think there's unfortunately different standards outside of California with non-California licensees versus California licensees and understanding our laws and regulations versus that are not. And I do feel extremely concerned. So I think that I'm going to continue to solicit more information in that case. So we're probably going to skip on agenda item 12 today, which is actually trying to see if we would come to consensus on regulation. And I will solicit more information from stakeholders if anyone is willing to give us any more information on it. So we'll proceed on that. Jason, your hand is raised.
I think that residency issue is something that the board, at least the committee, has certainly went and expressed their support for maintaining in-state services and operations. So I think if they want to speak to that, that would be informative to the committee and the board.
Absolutely. All right. It's probably opportune time for us to take a quick break. It's 3:20. We'll come back in 15 minutes at 3:45. We have a couple more items. Very important though, that's left. So we'll see you all back. Please hang in there. All right, it's 3:45. We'll get right back on it. We're almost through the end. I know our member Barker is going to be a little late, so hopefully she'll join as soon as she can. The rest of our members, I just see Trevor for now. So Trevor. You are here, right? Trevor?
Yes, I'm here.
Thank you, Trevor. Jesse?
Sorry, so I wanted to turn on my camera.
Okay, thank you. And Jason.
Here, Sung.
Thank you, guys. Thank you, everyone. Okay, so just a reminder again, we are not tackling agenda item 12. We'll continue to hear more information and solicit more information and provide more information to our members, and then we will tackle on that possible regulatory change in the next upcoming meeting. Next agenda item is 13. Discussion and consideration of licensure and other requirements for non-resident pharmacies. As I have previously shared, I am concerned about the board's inability to regulate non-resident pharmacies, including mail order pharmacies. Non-resident pharmacies can create unique challenges for patients. I can recall investigation that resulted in discipline stemming from these challenges that are placing patients at risk. Over the last 2 years, the board has referred 11 non-resident pharmacies to the Office of the Attorney General for formal discipline and issued 39 citations. In addition, the board took disciplinary action on 12 non-resident pharmacies. The underlying violations vary in egregiousness and include extremely serious causes of action, including clearly excessive furnishing of controlled substances. As a reminder, there is currently no requirement for pharmacists working in these non-resident pharmacies that are providing services to California patients to be licensed in California. In addition, non-resident pharmacies in general fills extremely high number of prescriptions and can have big impact if things are done incorrectly. As a quick reminder, the board has previously voted and will be still pursuing a statutory change to require the pharmacist in charge of a non-resident pharmacy to be licensed in California. Today, as we continue our discussion and consider if other possible changes are appropriate, the meeting materials include some questions for our consideration. Before we begin consideration of the questions included in the meeting materials, I want to note that I'm very concerned about the actions undertaken by some states to eliminate law and jurisprudence examination, as well as recent actions by Michigan and North Dakota that allow pharmacists licensed in Canada to reciprocate, with all due respect to Canada, licensure without taking the NAPLEX, which is the examination. I will not try to write that out, that acronym, NAPLEX. Moving to the questions included in the meeting materials for our consideration, the committee has previously indicated that inspections should be performed at non-resident pharmacies. So, question we're starting, does the committee wish to establish a minimum frequency for conducting such inspections? I believe every 4 years at minimum may be appropriate frequency, and would suggest that we tie the requirements to the renewal of the license. Based on the July 2023 statistics, the board renewed 499 non-resident pharmacy licenses in fiscal year 22 through 23. Assuming that number remains about constant, the board would conduct about 125 inspections of non-resident pharmacies annually. I believe a statutory change would be necessary to implement the provisions. Members, your thoughts on this? Agreement? Disagreement? Jesse, go ahead.
Hi, Sung. Sorry, we're going back to the statistics you listed. So you said we renewed about 499 non-resident licenses. Is that right?
Yes, last year.
And then how many disciplinary cases, or was it citations that you were listing previously for a non-resident
Yeah,
license?
there was about 39 citations, but I think the period of time is not, I don't have that information. Anne can probably speak better on it, on the details.
Yeah, so I believe that President O included both the citation details as well as the disciplinary numbers. I think they were both included in there.
Okay, I wasn't seeing it in the materials, but I personally think that every 4 years is too infrequent, but I'm also trying to bear in mind that that's a lot of licensed facilities for our staff to go out and visit. It's a huge expense to the board, but I think it is necessary. I would actually probably recommend something more frequent than that, but I'd be open to seeing what everyone else thinks.
Thank you, Jesse. That's I agree. I would like more than 4, but I think that 4 was where just kind of a reasonable point of where to land, balancing that, as well as consistent with our current policy of inspecting every 4 years for our California pharmacies. So that's kind of where the 4 years started. But if there's a appetite to have more, I'm in support of that. Absolutely. Trevor?
Well, my question was answered. I was going to ask what the typical period for inspections and if this differed from that, but it sounds like the 4 years is the same as what we currently do.
Our current goal is every 4 years of routine inspections. Yeah.
And is there an estimate of, I feel like I'm the balance book guy today. Is there an estimate of the cost for this as far as increase in cost, or would more regularly doing inspections, do we anticipate it would result in covering the additional cost of having to go out of state and do all these things?
Anne, do you want to speak to that?
Yeah, I think at the staff level, if the board or the committee was looking for recommendation, I think staff would probably recommend at whatever frequency you believe is appropriate, we pursue a statutory proposal that will allow the board to recover the cost. We already have a good framework with the non-resident sterols. And so using that same process to conduct the non-resident pharmacy applications seems like a natural extension if that's what the committee and the board believe is appropriate.
Okay, thank you.
Thank you. Jason?
If Anne could follow up on, I was going to ask, is there precedent for the Board of Pharmacy going out of state? It sounds like there is. Could you please illuminate for me?
Yeah, happy to do so. So by statute, the board conducts inspections of sterile compounding facilities, both in-state and out-of-state, as both a precursor to licensure, as well as on an annual basis. So we do go out of state for those. And at times there are facilities that are on probation with the board. And as part of the probation monitoring, we may also be going out and conducting inspections consistent with the terms and conditions of their probation.
Okay, thank you for that. That's really helpful. So, knowing that we're not blazing new ground here.
Yes, we're not creating a new, yes.
A great expansion of the board. I would be supportive of, I think we've landed on 4 years. I think 4 years, I would support such a motion.
Thank you. Sounds good. Any other comments? Oh, and Renee is joining soon. That is awesome. David, can you please promote our member Barker? All right, while you're doing that, I'm gonna move on to the next question. So as I previously mentioned, 2 states, actually since Renee is in, you know what, I'll just allow her to respond to the first question while we're talking about question number 2. 2 states, North Dakota, go ahead, David, to the next slide. North Dakota and Michigan have recently taken action to recognize pharmacists for licensure by reciprocity under specified conditions. It is my understanding that in Michigan, for example, and Renee, just so you are on the same page, we are on agenda item 13.
Okay, I just wanted to say that it's Renee Barker and I am back.
Thank you, Renee.
Yeah, thanks.
It is my understanding that in Michigan, for example, an applicant for licensure as a pharmacist in Michigan that has passed the Pharmacy Examining Board of Canada Pharmacist Qualifying Examination, completed an educational program accredited by the Canadian Council for Accreditation of Pharmacy program, and who has a minimum of 1,600 hours of pharmacy practice either through an approved internship or practice as a pharmacist, would meet the requirements for licensure in Michigan. It is my understanding, again, in the case of Michigan, there are 11 non-resident pharmacies licensed in California, in Michigan. So in such instance, a pharmacist providing services into California has not demonstrated a minimum competency on an examination that meets the requirements of Business and Professions Code Section 139, would be practicing pharmacy in California patients. So that is my concern. And so wanting to kind of get your thoughts on it. I do understand that it would be almost impractical or impossible to require every pharmacist to be licensed in California who are providing services to California. But we're hoping to see if there's anywhere we could improve upon so that we can make sure our California patients are getting the highest standards possible. Members? Anyone has any thoughts on this? Oh, Renee, you're sorry. I thought you were trying to talk. It's okay. If there's no concerns with this approach, I can explore further if there's anything else that we could be doing to possibly have some better standards of these practices so that maybe there's a way for us to prevent pharmacists who are not fully vetted in California standards or practicing pharmacy into California patients.
Hey, Sung, how does the FDA interface with this? I mean, given that this is across an international issue, what role does the federal government have in facilitating these licensure exchanges?
And I'll probably have you speak on this, but just from my understanding of it and explaining a little bit of having some understanding, just very little, each states decide, as our constitution and the state laws are designed, licensing of the medical professionals is done at the state level, and each state has its own laws and regulations of how to license their medical professionals. And the only entity that really gets kind of involved is an association of National Association of Boards of Pharmacy, who administers National Pharmacist Licensure Examination. So that's the extent. And you can add further to my possible inaccurate description of the current state of the licensures.
So actually, I think you did a great job. It's kind of like a ditto. It's regulated generally, pharmacists are regulated at the state level. And so, whereas, drug importation or something like that, the FDA might have a touch point specifically for a pharmacist. It's determined at the state level. So it's my understanding in those states, the state laws have been updated to allow for this practice, this kind of reciprocity.
And so this isn't allowing someone living in Canada to be a pharmacist. This is someone who, say, they move to the state and get their license there.
Well, I mean, that's up to Michigan, right? So if the pharmacist living in Canada who's licensed in Michigan lives in Canada, I mean, we don't know. So, Jesse, I'll go to you and then I'll continue on with our discussion.
Do we know, is there just one standard licensing exam in Canada, or is it province specific?
If that question is for staff, I don't know. We're not super familiar with the licensing standards in Canada, but can look into it.
Okay. I was just curious. I've just had a few Canadian pharmacist friends. I know that from what I understand, it's a pretty extensive licensing process, and this is a very peculiar situation that we're kind of faced with on jurisdiction and ability to oversee some of the licensees. So I'm just curious. Thank you.
So moving forward in our discussion, so the meeting materials provide a few follow-up questions, as you can see. First, if the committee wishes to prohibit such pharmacists from providing pharmacy services for California patients. So at least that may be at least one thing we can do is, but would require probably statutory change. The board has a requirement for non-resident pharmacies to ensure that a pharmacist whose license has been revoked in California is prohibited from providing pharmacy services to California patients. But should the board require pharmacists working for non-resident pharmacists to be licensed in California, that may be a little too far, but there may be a prohibition for pharmacists in certain circumstances from being able to practice and verifying medications to California patients. What's everyone's thoughts on that question? Or another side, if you all are okay for pharmacists who are licensed in Canada and Michigan to be able to practice pharmacy in California. I mean, that's, we may, that's also a possibility for our members for us to ponder about. So
I'll say I'll be interested in hearing the public comment on this one. I personally need a little bit more perspective on this as far as about the implications of it. I mean, are we talking about 5? Are we talking about 500? Are we talking about opioids prescriptions that are going on here from out of state that are severely concerning? Are we talking about something less? And so these are kind of the question marks in my head that prevent me from really having a solid opinion on this.
Gotcha. Okay.
Um,
Jesse? Go ahead, Renee. Sorry.
Oh, well, I just wanted, so, sorry, yeah, just kind of coming into this discussion, but I'm confused because I've had multiple graduate interns in my experience, so, pharmacists from other countries. And it is, there are a lot of, there's a lot they have to do to finally take the California exam. And so I'm just curious. I know it's most likely the proximity, but is that the only like reciprocity that they're giving is to Canada?
Sorry, Renee. I think sorry, let me just make sure I explain. So the concern was that the practices of non-resident pharmacies, and there are non-resident pharmacies everywhere, right, outside of California. And each non-resident pharmacies follow the state laws.
Mm-hmm.
And each that state, what we discovered is that Michigan is now allowing a pharmacist licensed in Canada to be able to reciprocate their license to Michigan, so that essentially it is a bifurcation of licensure process, right? And that pharmacist licensed in Michigan can possibly be able to practice pharmacy, and non-resident pharmacies located in Michigan with that licensure, there's nothing that stops from that pharmacist to be able to verifying medication orders for the patients in California. So that hopefully makes sense.
Yeah, thank you.
Okay. Jesse?
Sorry, I think my hand was up from before. I'm notorious for that.
No worries. Trevor?
Yeah, okay. I think I have a little bit more clarification of how I'm thinking about this. That's in line with what you were thinking about. Maybe there's a statutory or regulatory way, because the idea of this chain link of reciprocity, of that this person is reciprocal with this, or this nation is reciprocal with this nation, which means they're reciprocal with this nation. I definitely see the issue there. And I think even beyond just the out-of-state nature, if we want to do out-of-state licensures or whatnot, I realize that's a bigger question that we need to have a conversation about. I do think, kind of going on this Canada link, and I mean, let's just draw it out to a bigger one. Let's say there's one in Australia. Let's say there's one in anywhere where these states decide to have an international reciprocal thing. I think it would make sense and be reasonable for regulation, statute, whichever, to say that, to break that link and say, like, our reciprocity is only with this specific entity, and not one in our reciprocity does not extend to other partners recognized by this state or this country. And that would kind of put a fail-safe on there, so that someone from 3 levels down the reciprocity chain aren't able to finagle away into the California market, potentially with lackluster standards. So I guess I'd put that out there. It doesn't quite nail the issue of out-of-state licensure, but it at least puts a firewall from a reciprocal chain effect going out from there. So I guess I'll throw that out there.
Thank you, Trevor. I know this is a tough question. This was just kind of add on to the non-resident pharmacy discussion. And so I'm not trying to complicate too much today or give anyone a heart attack. I just wanted to get this discussion started. We can probably explore further on this question, and then we can have some next steps possibly in our subsequent meetings. But just a reminder again that the PIC licensure requirement is already supported by the board, and that we are going to seek statutory change on that in the sunset next year. All right, members, any thoughts on this before we move on? Jesse, your hand is up, but I think you're tricking me here. So I'm going to, okay, all right. All right, we're ready for public comment. I'm curious to hear some public comment on this. I'm sure there will be a lot of public comment on this.
We are open for public comment via WebEx. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of your screen. Dial-in users dial *3 to raise a hand, and we will call on people in the order we have requests. Don't forget, we also have a comment box in the a Q&A box in the lower right-hand corner of the screen where you can type the word comment to queue in line. We're going to start with John Gray. We're going to send you a request to unmute your microphone. You will probably need to dial *6 in order to unmute. You'll be given 3 minutes to speak, and I'll give you a 10-second warning.
Hey there. Thanks for that. This is John Gray, registered pharmacist with Kaiser Permanente. Just wanted to comment on the piece related to the California Board of Pharmacy inspecting non-resident pharmacies at some fixed interval. I would also encourage the board to potentially look at what other jurisdictions are doing. There are many other states that have statutes on the books that in some way require inspections of non-resident pharmacies at a set frequency. Many jurisdictions allow for the non-resident pharmacy to submit an inspection report from the resident state or a third party like NABP's VPP program. That might be a balanced approach for the board to consider, in that if you receive an inspection report from a non-resident pharmacy, from their resident board, the inspection report is completely clean. Maybe that gives you a level of comfort, but if there are elements on the inspection report that are concerning, that could be a trigger to send a California Board of Pharmacy inspector to inspect. So just wanted to encourage you to think about if there's a balancing approach so that you're not having to find a way to send your inspectors to the many non-resident pharmacies that you currently license. Thanks for the opportunity to provide comment.
Thanks for the comment, Dr. Gray.
All right, next we're going to hear from Stephen Gray. Hold on just a moment. We're going to send you a request to unmute your microphone.
A relations reminder to everyone.
That's of John. He's not a relative. I don't want that to be implied. I'm confused. The NABP stands for the National Association of Boards of Pharmacy, but the NAPLEX, it says the North American Pharmacy License Exam. And according to the internet, that exam is used for Canadian pharmacists as well as those in Australia and New Zealand, et cetera. So that might be one thing you want to check out to see if that's still valid. If your concern is what is the licensing exam that is used by Canada and how that may affect your decision on whether to accept the reciprocity from Michigan, et cetera. So I just want to point that out. Regarding the inspection of pharmacies, I fully support that. If California had been inspecting the Massachusetts pharmacies, California had its own tragedy with sterile compounding and learned a lot from that. If California had been inspecting the New England Compounding Center tragedies, may not have happened. And so I really encourage you to inspect. Fortunately, it did not affect California residents very much, but it did affect 700 other people in the United States. So I encourage inspection. And I am very concerned, though, that if you're going to require a pharmacist who is practicing clinical pharmacy, in other words, giving advice or helping to treat patients in California, and they're licensed in other states, requiring them without doing any dispensing or compounding requiring them to have a license just to give their advice would severely limit the options for California residents to get expert care. An example would be, was already the Cancer Center in Houston pharmacist was very concerned that if he gave advice on a patient-specific basis in California, that he would be prosecuted in California. And that concern was based on the fact that Missouri had prosecuted such a pharmacist who was just giving advice on treatment for a Missouri resident and ended up with a felony warrant of arrest if they ever tried to visit Missouri. So there may be a distinction you want to draw, of course, with the PIC, or maybe a distinction even for someone who's doing sterile compounding or something of that nature. But just giving advice would severely limit the care that patients could get from centers of excellence across the country. Thank you.
Thank you for the comment, Dr. Gray.
Next, we're going to hear from Lori Walmsley. Hold on just a moment. We're going to send you a request to unmute your microphone.
Good afternoon, board members. Lori Walmsley on behalf of Walgreens again. Appreciate the discussion here on non-resident pharmacies. I do agree with John Gray's suggestion with looking at allowing pharmacies to provide a home state inspection or the blueprint inspection through NABP as an option as well. I do think that this is going to be a pretty hefty lift for the board to go out and visit every potential non-resident pharmacy, and that may not be the best use of the board's time. Focusing on pharmacies that may have prior disciplinary action or inspection violations would probably be better suited to the board's, to the inspectors' most efficient use of their time. I do want to express some additional concerns with potentially requiring all pharmacists providing services into California to be California licensed. I know you guys didn't touch on that very much, but I do think that there would be some significant concerns across the country with pharmacies being able to continue to provide services that are already occurring into California. If that were the case, as a reminder, old pharmacists like myself that have practiced since before 2004, California did not accept the NAPLEX prior to that time frame. So a pharmacist like myself that's been licensed and continually practicing since before that time period would actually have to go back and take the NAPLEX exam, which would be a significant barrier for pharmacists. Also, the CPJE exam I do not believe is offered in all 50 states. So again, that would be another hurdle to look at considering if that was a requirement for pharmacists that practice, every pharmacist that practices into the state. I think that, you guys heard earlier today from ASHP around the accreditation standards. Colleges of pharmacy also have accreditation standards that are set forth by ACPE in terms of an accrediting body. So the education is standardized across the country. So not sure that there would be the patient safety benefit necessarily to require that for every pharmacist practicing into the state. Appreciate the time for the comments.
Thank you for the comments, Lori.
Next, we're going to hear from Sarah Polomu. Hold on just a moment. We're going to send you a request to unmute your microphone.
Hello, can you hear me?
Yes, go ahead, please.
Okay, thank you. Sarah Polomu with the California Community Pharmacy Coalition again. Thank you to the committee for the discussion regarding mail order at the last meeting. Mail order is an essential service for patients, both for patient access and convenience. We understand that the discussion has shifted more broadly to requirements for non-resident pharmacies, but we're concerned about requiring licensure for pharmacists outside their home state and the barriers this could create for access. It would be extremely burdensome and costly to license all the facility pharmacists in specific states, as generally reciprocal licenses are recognized so long as the pharmacist is licensed and in good standing in the state where the pharmacy is located. An alternative approach for the board could be to explore licensure compacts or reciprocity agreements. Given the workforce challenges in pharmacy, it may be helpful to Californians' pharmacy access to minimize operational burdens, like filing for and maintaining multiple licenses that keep pharmacists and techs from focusing on patient care. The CCBC does, however, appreciate the board looking into this, and we believe the Sunset Report is an appropriate way to continue examining the issue. Thank you so much.
Thank you for the comment, Sarah.
Next, we're going to hear from Mark Johnston. Hold on just a moment, Mark. We're going to send you a request to unmute your microphone. Mark, are you with us?
Hello, can you hear me?
Yes, go ahead, please.
Thank you very much. This is Mark Johnson with CBS Health, and I wanted to quote some statistics that we heard at the NABP 6, 7, and 8 district meeting in Wyoming last year that members of the California board attended. This was a presentation that was given by AACP, and it had to do with decreasing pharmacy school graduates. In 2018, across the United States, there were 15,192 students enrolled in all the colleges of pharmacy collectively. The 2023 entering class was only 9,324. The attrition rate has stayed pretty steady, you know, folks that leave pharmacy school once being enrolled at 12.8%. The next statistic I'd like to list is the NAPLEX passing rate. One could argue that the decrease has to do with the quality of student being accepted to pharmacy school. But in any matter, back to 2018, when we had 15,000 students, the pass rate was 89.1%. Last year, the pass rate went down to 77.5%. So if we apply all of this math, the graduating students who pass the exam in 5 years has decreased from 11,275 to 6,019. That is a 46.1% decrease in licensed pharmacists each year. And I realize these are national statistics and not California statistics, but I imagine that California statistics are very similar. Because of this, the Federal Trade Commission has asked states to consider parameters that would increase license portability. That's what Michigan did. You know, I don't know if Canadian pharmacist is the answer to the pharmacist shortage or not, but they're trying to do something inventive and outside the box that the Federal Trade Commission is asking for before the feds do it for them. So in the theme of increasing license portability that boards of pharmacy are talking about across the nation, you know, this talk of decreasing license portability and requiring all non-resident pharmacists to be California licensed bucks the trend and is the exact
10
opposite of
seconds.
what.
Continue, please. You have 10 seconds.
Lost you, Mark.
It is realistic and will exist. Thank you very much for the time.
Thank you, Mark. Thanks for the comment.
Gonna make one last check, but I think that was it. Yes, that was our last request for public comment.
All right, thanks, David. Members, any lasting thoughts, moving on to next agenda item. Jesse?
I think so. Just a note, there were a couple of public comments in regards to accepting an alternative to an actual in-person inspection. I would not be comfortable with that. I think as we said, California standards tend to be higher. And so even if there is an accepted standard or blueprint that NABP provides, I think that we should aim to actually have in-person inspections in our non-resident licenses.
Thank you, Jesse. Thank you for the comment. All right, we're ready to move on to next agenda item. We're almost there. Next is one of the last but not least at all. I'm very excited for this topic, discussion and consideration of proposed amendments to pharmacy law to transition to a more robust standard of care model for some pharmacist provided patient care services. The meeting materials detail relevant laws and regulations generally detailing the scope of practice for pharmacists. As a quick reminder, as required by the board's last sunset review, the board was required to evaluate if moving to a standard of care enforcement model was feasible and appropriate for the regulation of pharmacy. Again, the board was required to evaluate if moving to a standard of care enforcement model was feasible and appropriate for the regulation of pharmacy. The board, through an ad hoc committee, took a deep dive into the issue and ultimately concluded that the board's current hybrid approach to the regulation of the practice of pharmacy is appropriate. At that time, the board noted that based on information received, California patients would benefit from pharmacists gaining additional authority to provide some patient care services consistent with their respective education, training, and experience. Any such change would require legislation. Today, we have the opportunity to begin discussion of potential statutory language that could facilitate such transition. Included in the meeting materials is draft statutory language that was prepared to assist the committee. This, to me, is very reasonable starting place to initiate our discussion. I believe the basic tenets of the proposals are appropriate. To quickly summarize in concept, the proposal would expand provisions for pharmacists to perform CLIA waive tests beyond those currently allowed in BPC Section 4052.4, would allow pharmacists to perform a therapeutic interchange under specified conditions, would establish authority for pharmacists to furnish FDA-approved or authorized medication that is preventative or does not require a diagnosis under specified conditions, would expand upon pharmacists' current authority to administer biologics, and would allow pharmacists to furnish an FDA-approved or authorized non-controlled medications for the treatment of minor non-chronic health conditions or for which a CLIA waive test provides a diagnosis and the treatment is limited in duration, would expand current authority for pharmacists to complete missing information on a non-controlled medication if there is evidence to support the change, and would expand authority for pharmacists to substitute medications that are generally considered interchangeable, i.e., if the insurance will only cover one medication, but an interchangeable medication was prescribed. Last, would allow for medication therapy management and adjust treatments to manage chronic conditions diagnosed by a prescriber to optimize drug therapy, i.e., adjusting medication dosing in response to laboratory tests, such as warfarin or medication to better control diabetes. While I realize for some this proposal may seem too expensive, and to others it may not go far enough, I believe it provides a good starting place for our discussion today. I welcome your comments on the general provisions, members. I know it's very long statutory proposal in there. Maybe it's best that we hear from the public first on this, and then I'll come back to all of us, if that's okay. All right, we'll go to public comments. Sacramento, anyone there? Looks like nobody is there. We're ready for WebEx. I would imagine that there will be some comments on this, hopefully, or maybe everyone has fallen asleep today already. Hopefully not. Okay, David.
I don't think they've fallen asleep. First, we're going to hear from John Gray. And for everyone else, please put that hand up when you are ready to make a comment. We will call on you in the order received. Tap that hand button at the bottom of the screen. Dial in users, dial *3 to put a hand up. You may also type the word comment into the Q&A box in the lower right-hand corner of the screen. All right, John Gray, you will need to dial *6 in order to unmute. Hold on just a moment. I'm about to send a request.
Hi, thank you. Good afternoon. This is John Gray, registered pharmacist with Kaiser Permanente. Thanks again for the opportunity to comment. Just want to comment on a couple of the items in the draft statutory language. First of all, I want to say we really appreciate that the draft statutory language would clarify that prescriptions that are issued by a pharmacist pursuant to a collaborative practice agreement under the current Business and Professions Code 4052A13 are valid prescriptions. Those are the changes that are proposed, I think, in 4051 and 4040. This is very important. I can say that we have held back on leveraging 4052A13 because of the discrepancies in 4040 and 4051. So we're glad to see that language there. And secondly, the other comment I want to make, and I believe that the proposed statutory language supports what I'm about to say, but I just want to put it out there to be sure that that's what you all are thinking, is that we would encourage the committee to recognize that some of the new proposed tasks in the statutory language for 4052, for example, pharmacists sort of independently doing therapeutic interchange or furnishing a preventative medication could also be done pursuant to a collaborative practice agreement. And so we wouldn't want, the only way for a pharmacist to do therapeutic interchange to be under that specific authority. We would want to continue to have the ability to do it under a collaborative practice agreement, right? It's not one or the other, it's both. So those are the two specific items we wanted to comment on. Again, this is a very important topic, and just great to see it on the agenda. So thank you very much for the opportunity.
Thank you, Dr. Gray. Thanks for the comments.
Right, next we're going to hear from Richard Dang. Hold on just a moment. I'm going to send you a request to unmute your microphone.
Pharmacists Association. Thanks for the opportunity to comment. As the board knows, I've been engaged with you on the Standard of Care Ad Hoc Committee as you went through the process. I reviewed the draft language, and I would like to take the opportunity to thank the board for its proposed language. Really looking at the proposed language that was put forth, it is very comprehensive, and I really greatly appreciate the approach that the board and the staff have taken to put together this draft proposal to move our state towards that standard of care model, and following up on the report that was sent over to the legislature. A lot of the amendments and changes really incorporate a lot of the discussions and public comments that were received during the ad hoc committee. So I just want to commend the board and staff for its comprehensive review and proposal that it has put together. The California Pharmacists Association supports the board in its current approach with the proposed language, and we look forward to supporting it as it continues to move forward throughout the process in the coming months and year. Thank you.
Thank you for the comments, Dr. Dang. David?
Apologies. I was talking without anyone listening. Next, we're going to hear from Susan Bonilla. I hope that's how I say your name. Please go ahead when you're ready.
Can you hear me?
Yes, go ahead, please.
Oh, great. Yes, you got the name right. Thank you. I appreciate that, although I frequently mispronounce a lot of names myself. Susan Bonilla here on behalf of the California Pharmacists Association. I too want to echo what Richard Dang shared. We are really encouraged to see the language that's come forward. We believe that this puts California actually, right in line, if not at the front of the pack for what's happening across the nation. And I think, what's exciting for me is to understand, the underpinning here is really wanting to release this profession to be able to function in a way that's going to end up with better patient outcomes and also, frankly, help with the affordability of healthcare. So sometimes I think we can look at this and we get into the the specific details, but I just wanted to comment on the fact that I feel that this is the board demonstrating a really clear view of where pharmacy needs to go, and really the issues of equity and access are going to be helped as we pursue this path. So I want to thank you for really considering the broad healthcare system and the role that this move towards standard of care is really going to help the entire system, as well as really releasing some of the barriers that have kept pharmacy from performing in the best interest of patients, in the best interest of equity and access for patients in California. And ultimately, I believe our one best shot at achieving better affordability in healthcare is this pathway of standard of care, and the fact that with prevention, early intervention, the work of the pharmacist, we can achieve better affordability for the healthcare system and for our patients. So thank you very much. We look forward to continuing to work with you.
Thanks for the comment, Susan.
All right, and next we're going to hear from Stephen Gray. Bear with me just a moment. I'm going to send you a request to unmute your microphone.
Thank you again. First, I'd like to agree and compliment John Gray, Richard Dang, and Susan Bonilla for their views and their work that they've done on behalf of the association and pharmacists, and most of all, patients. I agree especially with John Gray's comment regarding the clarifying in 4040, section 4040, that pharmacist prescriptions, what we call initiation, are really prescriptions. That's very important. However, I think that in addition to changing the Business and Professions Code, those references to 405 2.1, 405 2.2, 405 2.6 also exist in many places in the Health and Safety Code. And for clarity and for the protection of both patients and pharmacists, I would recommend that the board also take a look at making the same modifications in the Health and Safety Code to make sure, for an example, the law says that a patient cannot have a controlled substance in their possession unless it's prescribed, and then it limits it to 405 2.1, 0.2, and 0.6. So clarifying that all pharmacist prescriptions would authorize a patient to have a controlled substance if that pharmacist had their DEA registration, et cetera. The other thing I want to comment on, in a couple of sections, it's limited pharmacist prescribing they cannot prescribe for off-label uses. And I think the board should reconsider that. Off-label uses are not only prevalent, but they are in many cases considered the standard of practice. An on-label use is only what the manufacturer asks the FDA to approve in their official labeling of the drug. But off-label uses can often be the latest, the best therapy for the patient, and pharmacists would be limited then to not using them under this current language. Not only that, but California law already requires drug coverage for health insurance plans to cover off-label uses. There's some requirements that they have to be referenced in a peer-reviewed article or something of that nature. But I think it's important to remove that limitation, because that could actually hurt patients and inhibit pharmacists from being able to give the best care up to the standard of practice for whatever they're treating. Thank you very much.
Thank you for the comments, Dr. Gray.
And we're going to take a quick look around. That was our last request for comment.
Thank you. Thank you, everyone. Thanks for the comment. Members, any questions or comments? No need for any motion. Trevor?
Yeah, so, my question was going to be, what are next steps from here?
As you know, that there will be a gigantic motion for us to approve Sunset Report. So everything that we're talking is going to seep through all into that report, and we'll have a huge proposal, which we're going to have incorporating all this in December. So we don't and I mean, we could, but I think that for Corinne, please stop me if I'm incorrect, but from my understanding, there will be a need to have all these things combined into one package to approve to submit to the legislature. So I don't think that that at this point we don't need any formal action. We just need just wanting to make sure everybody's on the same page.
Yes, I agree with that, President O.
Thank you, Corinne. Sorry, Trevor.
Yeah, I just wanted to put out more of a statement and get confirmation of this because as I'm reading through the changes, I understand if someone were to be looking through the minutes of what we're getting consensus on, they'll see a bunch of strike marks through PEP and PrEP. They'll see a bunch of strike marks through contraception, a bunch of strike marks through naloxone, and they may think, why is the Board of Pharmacy removing all of these things? Exactly. So what I am bringing this up for is just for public confirmation that we are not removing any of the access to these things. We are simplifying to make them easier to access. Would you agree with that assessment?
Thank you, Trevor. That is very nice of you to. Yes, I'm glad. Thank you.
And would you agree with that assessment that we are
Absolutely. Oh, absolutely. That is the whole intent of this. Jesse?
Hi, thank you. So I actually have serious concerns about the proposed language as it is. I do think it's too expansive. There's a couple areas that I highlighted. So under section 5, where it says upon patient consent, perform therapeutic interchanges unless the prescriber has indicated do not substitute. I have a serious concern with not reaching out to the doctor before changing medications for patients' regimen. There's a lot of information, particularly in a retail pharmacy, that we don't have access to. So there may be reasons for a specific medication, for example, renal function or hepatic function that we may not have access to at the pharmacy level in an outpatient setting or in any disconnected system. So I have major issues with that one. Also under section 10, where it says to furnish an FDA approved or authorized medication that's preventative but doesn't require diagnosis. I think there's so much room for interpretation there. And what preventative means is also up for interpretation. So for example, if we're trying to prevent a heart attack, you may have someone who has diabetes and you may see a benefit in using an ACE inhibitor per ADA guidelines. So things like that, I think, can get really tricky. And I think there needs to be some sort of limitations as we're outlining it. I did have a question too under section 16 surrounding the immunizations and how that language differs from the current allowance of pharmacists to administer immunizations. Is that intended to address the issue with the EUA or emergency use authorization with the COVID booster? Do you know so?
So just touching, great comments, Jesse. And I think this is where, as this discussion goes further, I think that this is the mindset of traditional pharmacist practice, right? It's been very prescriptive, and then putting standard of care model into the pharmacy practice. And I think that the idea is not every practice of pharmacists is going to be decided by the language of the statutory language or regulatory language, and that it would be determined by you as a practitioner what's best for that patient. And that's the hope. And I think that's why I'm excited about this proposal, why I think this is the right way to do it, right direction to go, because, there are, I think in vast majority of circumstances, patients would benefit. The example that comes to me that is Novolog, Humalog for outpatient setting. It's essentially in 9.9 out of 10 times, the insurance covers one or the other. They're not going to cover both. That's just the way that has happened in this prescription market due to the contracting and insurance nature of things. And most patients would agree again, because that's just what the insurance covers. Now that the time and what I think unfortunate in this day and age of what we don't capture in healthcare system is the time wasted, and the time wasted of that patient waiting for possible delay in therapy, getting a hold of the doctor, talking to the nurse, all those time spent, and at the pharmacy level as well, and I think that there's just an opportunity to really increase efficiency in American healthcare by allowing pharmacists to be able to take care of things that I find it to be. I think we can use our professional education and judgment to be able to do so. So that's my thoughts on it. But I totally understand where you come from, and I think that's where we're gonna have to have this discussion as we move this further along. On that immunization, Anne, can you speak onto that? I know there was a reason for it, but it's escaping my head right now. So,
Yeah, I do believe that the language in here is fairly consistent with the intent of the prior legislation to cover the COVID vaccines at the beginning. You're talking about specific to the FDA approved, correct?
Yes.
Yeah, I believe it's where the FDA has approved it.
Great, thank you. Yeah, so
Go ahead, Jesse.
overall, I understand the intention. I think there is a need for more flexibility. In the standard of care committee, we talked about things like, if you get a hard copy for a C2 and the doctor forgets to handwrite their date or something like that, or you can see that it's another person's handwriting. I think there needs to be more flexibility in that sense. My major concerns come from, we want to give pharmacists that flexibility, but we're still, as pharmacists, we're still under the direction of whatever our company, our employer directs us to do. And, as these new things come out, we want to be able to have more structure. A lot of the pharmacists I speak to anyway, and that I work with, in implementing these sort of things, and be able to actually use our autonomy. And a lot of us still are not autonomous enough. So I fear that with keeping this as open as it is, there's going to be even more pressure from employers on the individual pharmacists to not be able to actually use their discretion appropriately.
Right, that's absolutely valid concern. That's right, and so that's where we're gonna have to figure out how, if there's any ways for and any opportunities for us to better serve Californians and balancing that. All right. Anyone else before we move to the next agenda item? Wow, it's almost there. We're almost there. Okay. Hearing none, I'm going to move on to next agenda item 15, discussion and consideration of licensing statistics. Members, the meeting materials include a summary of the licensing statistics for the first 8 months of the fiscal year. You also should have recently received updated numbers. I'd like to draw your attention to the processing times for individual licenses, which as of April 1st, 2024, was at or below 15 days for both initial applications and to process deficiency items. I note that unfortunately there are some site application processing times well beyond our 30-day processing times. This is in part because of the loss of staff, including a manager, but as a committee, we will continue to monitor the progress made by staff, and it is my understanding one position was recently filled. I would anticipate that as the vacant positions are filled, we'll begin to see more improvement, but just a reminder and shout out to all the licensing staff that all your amazing hard work you've done is making huge improvements in the processing times. So thank you for all your hard work. They've been working weekends, overnights, well, not overnights. They don't sleep at the board office, but they work late nights. So I thank you all for your amazing dedication and hard work. So thank you to licensing staff. Members, any thoughts or comments? Okay, we're ready for public comment.
All right, now is the time to raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise a hand, and we will call on people in the order we have requests. We're going to take just a few seconds now to see if we have a request for public comment. And as a reminder to our mobile device users, if you're having trouble finding that hand button, please tap the ellipses button, that ... at the bottom, to find the appropriate page with the hand button. All right, looking around, I see no request for public comment. Do you wish to continue?
Sounds good. Thank you. All right, we're there. We're here. Future meeting dates. Before we adjourn for today, I would like to thank everyone for your time and participation. Our next meeting is scheduled for July 18th, and we'll see you all in a couple weeks. Thank you, everyone, for a very, very long day of meeting. And I appreciate all of you for all you do for California consumers. Thank you, everyone. Bye-bye.